we may have to use
So they
that,
don't,
and that's fine.
okay, so they may not need the buzzer on the phone if they're doing that.
Yeah. I'll just have to sit there and hit the start button.
After some voice first, right? Did he have notes?
Yes, I believe so.
Because
This one. Yeah.
I had to turn it off for, okay,
Oh, come on, Neil.
yeah, I had to turn it off for
I was telling
Dr. White.
we were on patient. I have the game set up if we need those buzzers. Because that's what you're talking about, right? The phone buzzer?
Yeah, I have, it's just a website, but it's blocking it, which it didn't do like a few weeks ago.
Morning, Joyce.
The PowerPoint, which has the thing on there.
On that side. You want me to try on the phone?
Yeah, it wouldn't let me go to the host website, though, is what I'm saying.
What do I need to do? Oh, this one.
Okay, it works in here.
Does it?
Oh, okay.
It must just be over there.
Okay.
I tried it in my office and it didn't work. I've never done that before. All right.
Do I need to tell them to download something on their phone?
No, it's just in the browser. Do
Okay.
you want to test it by
I
doing ccg.buzz?
I can go ahead and have them pulled up.
They each have to have one on there.
CCG.
.buzz.
And
And then-
can you go ahead and tell the
Yeah.
Jeopardy people to go ahead and have that pulled up in
I
their
texted them this morning that I would send them the code. And
The
then
game code?
ZFDW. And I'll have this on my laptop. Okay. And then,
You want me to go ahead and do
yeah,
it?
just do a buzz just to make sure it works. So if one of y'all will run the buzzer.
Rolling.
Okay? Buzz when you're ready.
I'm Buzz. This is Buzz.
Turn it off, turn it back
Okay. Ready?
on. Try again. Okay.
And what do I have to do?
So like, basically, we'll like turn it off, we'll turn it back on, I'll read a question, they'll buzz. So it'll show like all four, if they all four buzz in order.
Ah, okay.
And then when we're ready for the next question, you just have to turn it off, turn it back on.
I can do that.
So the reason I like, the only time I get mixed up is if I'm like, because I have my slides animated to where I can read the question before they see it.
Okay.
So I'll read it and have to hit a button to have it animate on the slide, then I have to hit a button to go to the answer, then a button to go home, then I have to turn this off, so I just end up
And
getting.
then you want me to turn the buzzers on when it goes up on the screen? Right
Just
after you
before we
get-
start. So like after they answer the prior question, we can just reset it.
Okay.
And then I'll read the question,
And
because
then
I'll
at
see
the
it on
end,
the
I'll hit
presenter
buzzer
view.
on.
Mhm.
Okay,
And I'll read the
Okay.
question. You can hit the buzzer on like before I read the question.
okay.
Because like the whole thing with Jeopardy is like if I read it and they cut me off after the third word, I'll stop and I'll answer.
Okay.
So the buzzer can be on,
Okay.
and that's just all they'll get. They won't see it on the slide if they jump in before I'm
Okay.
finished.
I can do that.
All right, so let me make sure I can get this on my laptop here. You can use that. And then I'll be good.
Lisa, do you need a water or anything?
No, thank you.
Ryan, do you need water or anything? You can help yourself outside.
Thank you.
Good morning. You just make We have Ryan, and we have Lisa in the back, so if anything happens, they are our kings and queens.
Yeah.
Yay, sweet. And it does have for Zoom, so how?
There's no problem.
Oh, that's really cool.
mic is okay?
It is now. Good enough. All right, I think we're on YouTube, so welcome YouTube fans and people that are virtual. Appreciate this. I think my row is virtual. Welcome to the 50th Abramson Lecture Day. We're so happy to have all of you. We appreciate our Wilson affiliates that are here, family, friends, residents obviously, and some alumni. Welcome. So glad to have you. This lectureship started in 1976. Dean Moran, really, guys, he knows his name well, out of Emory, who did the first lecture on portal hypertension and the spinal renal shunt, which was avant-garde at that time. But since that time, it's morphed, and we've had 50 lectures. We've had some extremely academics, we've had private practice, we've had research, we've had people from all walks of life. And David Sapston is our second lecturer here. Denton Cooley. We had people from cardiothoracic, cardiovascular, and more recently, I've decided to kind of change the tenor of it just a little bit and get somebody who's really has contributed to this program for over 50 years. He's a candidate and a resident here, did medical school down in New Orleans. But Dr. Griffin, as is typical for him, bosses us all around. And as I had dinner with him last night, I said, Dean, when are you going to show up for this lecture? He goes, I'll show up I'll be there when I get there. So we're going to proceed as planned, and we have a full day for you. The first presentations will be by our faculty. We changed that to give our chief residents a little time to be with their family, to enjoy the presentations, and we can still ask them questions throughout the course of the day. But we'll start with Dr. John Savoy in general surgery, followed by Dr. Pennywell in the thoracic case, Connor McDaniel in trauma, and Dr. Keller in oncologic surgery. Dr. Griffin was well versed in all of these, and I'm sure he asked last night, he goes, why do you have the faculty do it? I'm very inquisitive with that, because he's been to every conference that's known to mankind in this institution. We'll follow with surgical Jeopardy. Donnie, I guess it's the first year that Donnie's not going to do it, Brad's going to do it this year, and then we'll follow with the break, and I'll give the dreaded history of the Department of Surgery. I'll try to do this every 3 or 4 years. I try not to do it every year. But I do have some more slides. I have some more history that really wasn't available, that I kind of dig deeper into it every year about what we do, what we've done here, and what we could do better. And then Dr. Griffin will give the Abramson visiting lecture. So without further ado, Dr. Savoy.
Good morning, everyone. I'm John Savoy, one of the general surgery attendings. Thanks for allowing me to present. Congrats to the chiefs. I'm going to be presenting a case of management of a complex EC fistula after an emergent strangulated umbilical hernia repair. I have no disclosures. So our patient's a 50-year-old male with a history of asthma, heavy cigarette smoking, and a trauma laparotomy via large transverse incision after a car wreck 20 years ago. He also has a history of the umbilical hernia repair with mesh in 2017. Of note, I looked at the op note from this umbilical hernia repair, and I blame the intern for this. I was in on that case in 2017. So, Dr. Griffin was the staff actually. He presented to the ER in December of 2023 with a few-day history of some abdominal pain, nausea, vomiting, and a non-reducible periumbilical hernia, which was a recurrence of this umbilical hernia that he had. He was stable and non-peritonitic on exam. This is a picture of his abdominal wall at that time, showing that large transverse trombolaparotomy incision. And here's his CT scan showing dilated loops of small bowel within the hernia and decompressed distal small bowel, is read as a partial small bowel obstruction. Now, the hernia was reduced and he had quick return of bowel function and his diet was advanced. So here, there's a couple different points in this presentation where, you could, decision points, and this was one of them. So what next? Should we, I know Dr. White wanted to ask some of the audience if we should repair this hernia now or try to optimize it a little bit.
You said who you think?
Okay. Yeah, so you have a smoker, he has a recurrent hernia. His BMI is okay, it's in the low 30s, but he is centrally obese. But he did have this obstructive episode. So I guess I'll pick on the Chiefs one last time. Harrison? What do you think?
In that setting, if it's reasonably BMI, I would probably go ahead and discuss that.
Yeah. Any other thoughts? No?
You could ask him to, if it's easily reducible, trustworthy how you could ask him to stop smoking for minimum 2 weeks, and then you're going to call and come back to it.
Yeah.
John, do you use any metabolic components, lactate, white count, in any of the decision making? So if all that came back normal, the lactate was fine, the white count was fine, he was not tachycardic, didn't show any signs of, late obstruction, sequestration of fluid, or obviously need compressors. How would you do that?
Yeah, we take all that into account. This was pretty straightforward. It popped back in, and everything was stable and fine. So my decision was kind of like, well, do we fix it like right now, inpatient, or do we send him out and kind of do it just as a later date? Some of the more recent data, they're showing that you can try to prehab these patients and optimize them, but they're showing that the outcomes for these hernia repairs, whether you try to get them to lose weight or stop smoking or control their blood glucose, the outcomes aren't necessarily that different. And some of the patients, when they're in the optimization phase, some of them are undergoing emergency surgeries, which you really want to try to avoid. I did opt to try to optimize him before surgery, so I followed him up in clinic. He was actually lost for about 6 months, but he came back and he was still smoking. The hernia was easily reducible, and he didn't have any further obstructive episodes. So my plan was to get him to stop smoking and get him to undergo an initial screening colonoscopy prior to doing a robotic hernia repair. He had never had one, and he was a smoker, and I thought it was just something that I should do. Now, this is where things took a change. So he underwent this colonoscopy in October of 2024, and 3 days later he came in with diffuse abdominal pain, nausea, vomiting, and no bowel function since prior to the colonoscopy. His vitals were stable. He was peritonitic. His labs were significant for an AKI. And CT showed a bowel obstruction with a transition point in the hernia sac, and now with signs of bowel perforation with free air and free fluid. So here's his CT scan showing the dilated small bowel within the hernia, small amount of fluid around the bowel near the hernia sac, and decompressed small bowel. So during the colonoscopy, I think some of the air got through into the small bowel and dilated and strangulated, and he was just strangulated at home for a few days. So no decision point here, where this was very clear we needed to take him to the operating room. So we performed a laparotomy. We entered the abdomen and the lower abdomen virgin territory. Dr. Keene helped me with this case. We found necrotic small bowel within the hernia sac and a large amount of contamination within the abdomen. He had a near frozen abdomen. We lysed adhesion, like thick concrete adhesions, for about 4 or 5 hours. We were able to kind of delineate the anatomy and resected about 100 centimeters of small bowel and debrided necrotic soft tissue, and included the umbilical hernia repair with our fascial closure. There were some serosal injuries which we repaired, which we oversewed and did some thaw patches on and things like that too. So his post-op course, he did fine the first few days, no issues. He did have an intra-abdominal fluid collection that was drained by IR, which was expected. However, on post-op day 5, he did have a large amount of serous drainage from his midline incision, and by post-op day 7, it turned feculent, indicating likely an anastomotic leak with a fistula. So I thought this was like a good decision point too. Do we take this patient back? It's still early, or do we try to manage the fistula conservatively? I'll kind of ask some of the chiefs, do you trust me? Any thoughts?
What's up, day 7?
Yeah, when it turned feculent, yeah.
Yeah, I feel like it's usually depends on the outbreak and try to.
Yeah. Any thoughts from the attendees?
Any other imaging? Did y'all do any other imaging to localize this? Feculent is feculent, but sometimes small bowel contents, and is there a difference between a colonic cutaneous or a small bowel enteroperitoneal?
We did eventually. At the time, I think we just went on the recent CT scan with the fluid collection that he had that we had drained. What I did opt for was just to try to manage it conservatively. And this paper I just kind of looked up, and this kind of focused on, it was a 23-year like retrospective review, and focused on like what increases the morbidity and mortality with managing these EC fistulas. But the timing of it, they said if you are going to, within the first 7 days, you can't consider going in and trying to resect and divert and things like that. But if you are going to wait, usually try to wait 6 to 12 months and let all the adhesions soften, and was the recommendation. Now, past 12 months, actually, the morbidity and mortality increased. So he had a long, complicated 6-month post-op course. All the residents know this patient well because they got paged constantly because of his pain medicine and his wound issues and things like that too. So I appreciate your help taking all those calls. So he had to go back to the OR about 14 times in the first 2 months for wound debridements, wound dressing changes. We did end up putting a J-tube in through the distal small bowel part of the fistula to give him nutrition. He had a PE, bacteremia, sepsis. He just needed extensive wound care. And so we weren't really able to find him placement or anything like that. So he was, during this time, we were kind of following the principles of fistula management. We were protecting his skin, trying to control the output with Imodium and Lamodal and octreotide and PPIs, and giving him nutritional support with TPN and tube feeds. We did kind of define the anatomy of the fistula with fistulograms with IR and CT scans, and we knew that was more kind of a proximal small bowel jejunal EC fistula. Here are some pictures of the progression of his wound. We used some drainage tubes to kind of control the output. This was his J-tube in through the proximal portion of the, I'm not sure if I can show it, but of the small bowel. And overall, the wound closed well. This is what he kind of ended up going home with, this large ostomy appliance and a crazy combination of ostomy tape and ostomy paste and Eakins rings and things like that too. At times, he had a lot of trouble controlling the output. It was a high output fistula, so he had some skin excoriation. This is actually how the wound looked on the day of the fistula takedown. Now, he also had about a 6-month outpatient course too, where he was performing wound care at home. He had continued tube feeds. He was eating by mouth and having like intermittent bowel function. I would see him basically weekly to make sure he had like enough wound supply, and he had a lot of issues with pain too. For 6 months, basically, he was on like round-the-clock Dilaudid. So I was giving him these like high doses of like roxicodone every week. I thought I was gonna like get arrested or something at one point. I was pretty nervous. He had continued weight loss. His BMI got down to around 20. I think he lost around 80 pounds or so. But we would check his nutritional labs, and those were always maintained. He did have some intermittent admissions for AKI and J-tube issues. These visits were tough. There was a lot of, just on like kind of the psychosocial part of managing these, there was a lot of anger on his end and his mom's end, and a lot of blame on my end, for this complication, this tough time that he was having. So it took a lot of perseverance on his end and our end and everything too. So we did eventually get him, so about a year later after his initial laparotomy, we got him to the point where he had stopped smoking, and we had optimized as best as we could. So we took him for a fistula takedown in November of 2025. Again, entered the abdomen inversion territory. We lost adhesions for only 2 or 3 hours this time. They were nice and thin, which was great. We isolated the fistula and confirmed the anatomy. We would use a red rubber catheter into the fistula because there were kind of multiple loops and holes like at the fistula site, kind of confirm what was proximal and distal. We resected 12 centimeters of small bowel and created our anastomosis and made sure he had plenty of small bowel left, and the fascia was closed. He recovered well. He was discharged on post-op day 11. He mostly waiting bowel function. His colon had largely been non-functional for about a year, as well as pain control and some anemia, but his course was pretty benign there. I've seen him in clinic a few times. This was March 2026. He immediately gained like 40 or 60 pounds back. He still had some issues with pain, but overall he's doing well. He was supposed to see me this past week. I saw him in the parking lot. He had some insurance issues, but he looked heavier than this now, and he looked good from the parking lot. So he's coming back to see me next week. So what I learned, this case took a lot of patience. It took a lot of just kind of emotional toll on me too. It was a lot of blame. And how I changed things, I'm less rigid on BMI cutoffs and optimization based on just experience of this and reading some of the papers too. It's that paper that I showed, they really kind of individualize everything to the patient and the hernia and everything too. I actually had a patient that I've been following for a few years, BMI 50 with a hernia. She came in recently with another obstructive episode that resolved, but I thought about this case and we ended up doing a robot repair to hopefully prevent an emergency surgery. And then I really couldn't find anything where a colonoscopy prior to a hernia repair was indicated, so I've kind of, unless they're having symptoms or problems, I'm more relaxed on that too, because I have a healthy fear of that now, so.
That's a great case. I'd like to comment on the psychosocial aspects of a prolonged hospitalization. How do you keep that patient, number one, happy? How do you maintain your compassionate approach to patients who have chronic wounds? And I can tell you, early in my career, I didn't pay enough time and really stay on course with, number one, being a better listener and a better talker on what we were going to do next. So, Kevin, you got any comments on, you burn patients? I can tell you that the advent of patients and taking care of patients this long term. Any caveats?
Yeah, I mean, the more difficult the patient is and the family, it tends to make attendings and residents spend even less time with them because you can't make unhappy people happy, but you have to continue to try to do so because we're not laying in the bed dealing with everything they're dealing with. I also have comments, and I'm glad you presented this case because it takes me back to resident year levels where we'd be in clinic and we'd be seeing a patient that had been seen 2 months before for an umbilical hernia, morbidly obese, and the plan was lose weight and come back. Well, the next scheduled appointment was always when that resident was no longer on that service. Let someone else. And my thought process then was, these people are not going to lose weight, and you're going to potentially put that patient and you in a position that they're going to come in with an obstructed, strangulated hernia, and you're going to have to operate under the absolute worst conditions. So I'm really glad that you pulled up that new paper showing that, we often try to maximize things when in reality, you're not going to get them to stop smoking. Now with everybody's on the shot, you can get them to lose weight, but will they come in obstructed before then? But
I will say that with the advent of the internet and the interpretation of pretty complex literature by the lay public, and you have a complication like this, is I've done a lot more listening, trying to intervene and saying, this is not our fault. It is okay legally to say I'm sorry for patient care, and I think we need to, as surgeons and healers and physicians, is to say, look, I really am sorry we had this complication. We're going to get you through this. We're going to day by day. The worst thing you can do, and you'll see in all of medical legal literature, is not patient abandonment, which is actually a legal issue and a problem, but it's just that ongoing compassion with them, and don't leave their site. Don't turn them over to another physician. Don't transfer them unless you actually can't take care of the problem. And most of the literature is pretty replete that lack of compassion leads to medical legal issues. And if they see that you're human and that you're with them until the get-go, like John was in this case, they tend to be a lot more forgiving. But sometimes they'll ask, can you call this doctor? What about this paper? Or can you speak louder into my phone? I want to get all this. It is really hard to keep your composure sometimes. And if you do, if you lose it, you lost the game. Yes, sir, Dr. Sabah.
Congratulations. I think you handled this case extremely well. Way back, I think that I can remember Martinez.
Oh, gosh, yes.
He looked at some 46, 47 intracutaneous fissulas, and we presented at Southeastern Surgical Congress in Nashville in a poster fashion. The speaker spoke at the podium and he referenced to the poster from LSU, and I was sitting beside McDonald, because McDonald would say, don't submit nothing poster. Bottom line is that those days, one of the biggest problems you have with high altitude fishing is the skin gets so eroded with pancreatic juice. Obviously, electrolyte and nutrition was a major, major problem. And it looked like your case, you managed to control wound very effectively, and you got to be patient to take the necessary time to go back in and take care of it. I think nowadays with robotic surgery, we use ICD. Clearly with your anastomosis, you could look at it whether or not anastomosis is well vascularized or not. I'm certain proximal dilatation, have something to do with repair and leak and what have you, but congratulations for taking patient.
Is there any role for some of the newer studies? And I know Dr. Boykin had mentioned endoscopically placed sponges to try to stop some of these fistulae. Probably not, but an intero fistula, maybe not an interocutaneous. Is there any application to small bowel enteroscopy?
You know what you rely on GI quite a bit with colonic and proximal duodenal fistulae doing endoscopic. In fact, we just had a patient with nucleotizing pancreatitis, had gastric fistula, had duodenal fistula, and they actually went in endoscopically, clipped it. Those fistulas were completely taken care of it and to extend to pancreatitis. But I've had probably dozens of colonic cases where radiology could catheter in, either iatrogenic or from necrotizing pancreatitis. You see colonic fistula. We managed actually to manage those in stock.
Don, thank you. Great case.
All right, well, good morning. This is a case that I did with Dr. Keller, actually a joint case with surgical oncology and CT surgery, chest wall resection. Our patient is an 87-year-old man, had a left upper anterior chest wall mass, had been slowly growing over a period of about a year, and really hadn't bothered him all that much. It was pretty much asymptomatic. It had gotten to the point now, though, where it was big enough that he was having trouble putting his clothes on, and his family was just getting concerned. He's got this thing here, what is this? And we need to get this checked out. So, and by the time he came to see me in the clinic, he was actually beginning to have a little bit of some symptoms, some pain in his chest wall and shoulder, and a little bit of trouble breathing just because of the heaviness and mass affected this tumor here. So like I said, slowly growing over the last year, really not a whole lot of symptoms, a little bit of trouble moving his arm around, doing some of the things that he wanted to do. Not surprisingly, he did have some comorbidities at 87 years of age, had some chronic kidney disease, had a distant surgical history of a partial nephrectomy and maybe some colon taken out as well, and he wasn't really sure what it was. We thought maybe renal cell carcinoma, but we couldn't find records. It was pretty far back. So that's the surgical history. Had hernia repair and no smoking, alcohol, drugs. Very functional man. Took care of all of his activities of daily living. Did a lot of housework and zone shopping, a lot of things like that. So he had this, like I said, this large tumor left anterior chest wall. We got a CT scan, which you can see the tumor here. Pointer shows up, it doesn't, but you see about the third rib is where you begin to see this tumor kind of encroaching, and then the fourth rib you can see a lot of cortical destruction and pretty kind of like ill-defined lobular mass here, and it goes down at least to the fifth rib. But no evidence of any metastatic disease on this CT scan of his chest. He had an MRI of the chest, abdomen, and pelvis. I'm going to show all the way to abdomen and pelvis. But again, you can see the tumor, and this time if you look at how the tumor kind of abuts the pericardium, there are a couple slices where you can't quite tell if it's invading the pericardium or not. right here, you can see it's really kind of pressing down on that pericardium there. So, let's just take a moment here and ask Dr. Darvish. You have this 87-year-old man with some sort of tumor left into your chest wall mass. We have these pictures that we just showed you. Nothing that looks like any metastatic disease. I guess two questions. What do you think it might be, and what would your next step be?
Looks like it's soft tissue.
Okay. You think maybe sarcoma? Okay.
What's your differential? Let's go through the differential of not only what you think it is, but what potentially it could be.
So neoplasm can be benign or malignant, right?
Think about the tissue layers of the chest wall and some neoplastic processes that can come from those different tissues. They all have different names. That's okay. Steve, fine?
It could be sarcoma, liposarcoma, osteo. I know there's a lot. I'm not familiar with all this. Bone tumors that could be originating from the bone. My next step would be to do a biopsy. I'd be able to just do it for work. I'm not sure.
What would you do? What would you do?
What would I do as far as
Yeah.
biopsy?
Right.
I'd probably just do a core biopsy, try to stay as minimally invasive as possible for now.
Okay.
Let's also go through some more of the differential. Ewing sarcoma, doubtful trauma related. But I got a case like this on my oral boards and thoracic, and I was ready to resect. You get so excited on your oral boards, you just want to go in there and operate. What are some of the infectious complications or some of the infections that can cause pretty dramatic chest wall problems? Miles?
I think we had a case, it was a fungal infection. I think, histio or, blasto. I think maybe it could be cutaneous and it's just invading deep, if it's, skin cancer or something like that.
That's good. How about something that can be amenable to penicillin? I'll tell you that. The sulfur granules. I've seen some cases like this. Very invasive. Actinomycosis. Blasto in an endemic area where there's cattle production, Texas blasto cases, coccidioidomycosis can't have chest wall involvement, lymphoma that really is not a sarcoma. There's a lot of different things.
One last question before we move on. Let's say, Dominic, let's say you get the corneal biopsy and it's non-diagnostic. Excisional biopsy?
Not the whole mass, but just the piece of the mass.
So what do we call that? It's not excisional, we call it a incision. Right, exactly, right. Very good. Well, this gentleman did get a corneal biopsy and it demonstrated a low grade, they said at least grade 1, but suspected it was a low grade chondrosarcoma. I said no metastatic disease, so I guess the next question then is you have chondrosarcoma, the one I just showed you pictures of. Let's ask Madeline, looks like it's your turn next. What would your next step be in this case? You have a confirmed diagnosis, you have no metastatic disease, 87-year-old man. What about neoadjuvant therapy?
It's grade 1, there's no meds. Maybe the safety model, maybe about radiation,
What do you think they'll say?
but
That's what they ask you on your board. You say that and say, well, what do you think they're going to say?
I don't think you would need to be very.
You don't think so? Okay. We'll talk about that in a minute. So, okay. So he was seen by both his cardiologist and an internal medicine doctor. None of them are affiliated with our institution. We did also have our pulmonologist see him here as well. And his cardiologist did a pretty thorough workup and told us that he was moderate risk for major adverse cardiac event with a moderate risk surgery, which is basically what we would have expected in an 87-year-old man with these comorbidities. Had a long discussion with him about his options, palliation, with, there was really not a whole lot you can do to palliate it. Watchful waiting versus surgical resection. He was very eager to move forward with surgical resection. So we planned him for a chest wall resection, and with the possibility of maybe some lung resection, pericardium. Couldn't tell for sure if it was stuck to or invading any of these structures. One other question, I guess. What kind of margins are you looking for in a case like this, a chondrosarcoma, the chest wall? You know what kind of margins you want? So at least 2 centimeters, 2 centimeters bare minimum. Some people say 4 if you want to really do a good wide resection. There are a lot of studies that show really good 10-year survival with a R0 wide resection. So we planned him for chest wall resection, including the involved ribs. And so in order to do that, we decided to use titanium plates. And so we started with a model, 3D model. You can see the tumor there, and we've also marked our planned margins on this model. Here's the same picture, just without the tumor in the way, so you can kind of see what we're potentially planning to resect. There's another picture with the tumor gone and the ribs along with it, and what our plates would look like, most likely. And so then we actually got a real 3D printed model that we were able to shape plates ahead of time, so that when we got to the operating room, we just put them on and they fit like gloves. We don't have to spend time shaping those in the operating room. So position him supine, left arm out, right arm tucked, A-line. Began with the superficial soft tissue dissection. I say superficial, I just mean outside the chest. It's really pretty deep dissection. This is Dr. Keller and the surgical oncology team performed this part of it, and this is kind of at the point where they have finished their work. The head is down toward the bottom of the screen. This picture is taken from over the blood-brain barrier with the anesthesia, and so you can see the hand there holding the ellipse of skin, nipple, breast tissue, and the tumor there is still stuck to the ribs. It was really not adherent to or involving the third rib, so we knew we could spare the second rib in that case for sure. So then we proceeded with resection of ribs 3 through 6, trying to maintain a margin, like I said, of at least 2 to 4 centimeters out from this tumor. And then it was stuck to the pericardium. The lung was totally free. As soon as we got into the pleural space, we could see the lung was down and out of the way, not at all involved, but it was definitely stuck to the pericardial fat, so we ended up resecting a pretty broad piece of pericardial fat. And so there's our final tumor. One picture looking at the posterior, the one on your left, shows a view from the posterior side, and you can see the pericardial fat and the pleura there on the posterior aspect, and then the other picture on your right. You can see, I think it's on your right now, it's on your left. So it's back to the one where you can see the posterior, and then here you can see the ellipse. Yeah, here, this is the pericardial fat right here, and then the pleura kind of over there.
How did you manage, obviously there's no way that the pathologist can tell you totally that these margins are all free. How did you manage that by not only just marking it for orientation, but how much credence do you place in those closes? Because, you know, frequently you'll get a negative margin where there's no way absolutely that they can check every section. You know, what's your thought process about that? You knew you were going to go around the finish.
Right. It's a good question. I don't know how well they can give us a good answer about frozen with a chondrosarcoma. I think the chondrosarcoma is a little more difficult to get a definite answer with that.
You know, I think gross margins, you know, 2 to 3 centimeter gross margins, as best as the surgeon can tell. I mean, like you said, well-differentiated tumors can mold into the tissue, and that negative margin may not be negative on the permanent.
Right.
So I think be confident in your resection margin, and sometimes you have to deal with the consequences when the frozen and the permanent.
And our decision with the pericardial fat, you know, it looked almost like we could peel it off the pericardial fat, but because it was a little bit stuck to it, we said we're going to just take a wide piece of this pericardial fat out with it. It dissected very easily off the pericardium. It was what looked like a virgin plane between the fat and the pericardium, so we didn't suspect there was pericardial involvement at that point. So once we finished this, we had a pretty sizable defect. You can see it's almost 15 centimeters across. And if you look at this picture, toward the head at the bottom of the screen, you can see that's lung down there. And then there's you can see the pericardium down below that with the kind of the rim of pericardial fat there. So at that point, we brought our plates in, we performed our reconstruction. Underneath the plates, we placed a gore dual mesh, preventing lung herniation, and that's kind of our final product. They were the plates and plate ribs 3 through 6. So after we finished that portion of the operation, then the OMFS team came and performed myocutaneous latissimus flap. Got a beautiful result. That's after we got back to the ICU, we got a good picture of his flap there. So his post-op course was actually pretty uneventful. He did have to get some Decadron and had a bronch the morning of post-op day 1. But then he was still extubated. Epidural was out by post-op day 3, floor status, got his chest drains out, pleural drains. He did still have some subcutaneous JP drains that he went home with ultimately. Discharged home on post-op day 6, didn't have to have rehab, went home, had a lot of family support, and had good help at home, just some home health to help with his JP drains. A couple days later, he had a near syncopal episode and went to an outside ER and then was transferred here. And if you look, this is his picture before he left, post-op day 6. And then if you look at this picture on post-op day 8, when he presented after his syncopal episode, you can see he's got a pneumothorax on there. I don't know if I can get this pointer. Where is it? Oh, there we go. So if you look right up here, you can see he's got a pretty sizable pneumothorax up there. So, back to this. So, well, show up anyway. So I was going to ask you all, what would you do about this? Would you put a chest tube in that? And what would hold you back from putting a chest tube in that? The problem is that one of the JP drains is slipped partially out. He had sentinel holes outside the chest, so he had air freely tracking back and forth, and that's how he got his pneumothorax. So, what would make you put a chest tube in this? And what would make you say, I really don't want to put a chest tube in this?
Totally asymptomatic, sat 98% on room air with this pneumothorax. Syncopal episode may or may not have been involved. He may have coughed, had a valsalva, and coughed out. Maybe the cough. So one thing I would ask myself, is there a hole in the visceral portal?
I would treat it conservatively unless there was an apiacycle shift on the chest x-ray. If it got worse over time and continued to grow while we watched it, or if it developed any symptoms. I would make sure that the drains were in appropriate places, and if they, like in this case, if it needed to be pulled out, I'd pull one out and then follow up the chest x-ray and see how it looked at that time.
What if it was a hydropneumo instead of just a pneumo? You had, estimate, you probably could not get a good CAT scan with the refractive nature of the hardware, but say if you had a hydropneumo, would that tend to make you want to put the tube in a little bit more?
I think it would depend on how large the hydrophoros was.
Well, he was, we're talking about, so he was asymptomatic. He was at 96, 98% on room air. We did pull that JP drain out, so we found the sentinel holes outside the skin. And our thought process with regard to placing a tube, he did have a little bit of an effusion here. I'll show you a CAT scan actually. He was ultimately discharged back home a couple days after he showed up with us. So this is his CAT scan. And you can see that he's got some air outside the pleural space, outside the rib cage. He's got the pneumothorax, and he does have an effusion here. So our thought process with this was, he was asymptomatic, he was sat in 96, 90% on room air. Instrumenting this area is, there's risk with that, right? If we instrument this area, we try to drain an effusion, we have an indwelling chest tube, we've got plates, we've got mesh, we've got a lot of stuff in there. If it gets infected, it's a catastrophe. So our decision was that less was more in this case. So we watched him for a day, and by the next day, a lot of his pneumothorax had resolved, as you can see on that chest x-ray before he was discharged. You can see most of that pneumothorax is gone now at this point. And so our plan at that point was, we've got this CAT scan, we follow up with another CT scan, see him in the clinic pretty regularly after that. He had no white count, he had no fever, there was nothing to indicate to us this was an infected fluid. So that was our thought process with that. He did come back to clinic, and this is a CAT scan a few weeks later, actually. And so I'll run through that. You can see the pneumothorax is gone, and the pleural effusion does still have a little bit of infusion, but it's smaller. And at this point, when he showed up in clinic with this CAT scan, again, totally asymptomatic, able to do actually more than he was able to do pre-op at this point. And we talked about draining this fluid. We even got one pulmonologist, you guys to see him talking about it as well. And he absolutely did not want to have anything instrumented in there and risk an infection. And since it was getting smaller, we decided at that point to continue to follow him, do another CAT scan, and ensure that this resolves ultimately. So 10 weeks out, this is him. You see his flap is well healed. He's got full range of motion, no neurologic or deficits with mobility. Pulmonary function is much better now than pre-op. And he told us he couldn't be after his final pass, showed actually a grade 2 chondrosarcoma. And he did have some tumor present at the posterior margin, but otherwise the margins were negative.
Who's the resident that was involved in this case?
We had a couple, right?
Okay, good. Did you stop and did you see the flap done by the consultants?
I saw a little bit of it.
What type of flap was it?
It was a lot.
Latissimus?
Yes, sir.
And it was, and what are some of the other flaps that you can use? And it's kind of two questions. Number one, is there a difference between an anterior neoplasm and a posterior neoplasm on the chest? Do you treat them differently? Whether it's a lung cancer emanating from the inside of the chest or an ectothoracic tumor digging down into the muscle. And what would you do differently if, say, this was a posterior mass, it was a 3 centimeter mass, not a 7 centimeter mass, and it was, say, in the posterior axillary line versus the anterior axillary line? Because there's differences in resection technique, reconstruction. What I'm trying to get at is that anteriorly, patients don't tolerate anterior lesions that have resections over 3 centimeters because the sucking nature of the chest, the paradoxical motion, it's like having a sucking chest wound. Even though you may cover it, you're going to get some problems. You're going to get fluid deposition in there, and you have to reconstruct something originally. Now, if it's more posterior and it's relatively small, you can use thoracic muscles to cover that space, maybe without rib reconstruction, or maybe with a more rigid mesomethacrylate type of scenario. But I think proximity to the muscles is extremely important. What are some of the non-thoracic muscles that you can use to cover spaces in the chest? Something that's not a thoracic muscle like the lat, the pec, those muscles like the serratus and things like that that you can rotate. Say if you didn't have that option, say if they had a thoracotomy. Miles?
Rectus.
Rectus, yep. Tram. What else?
I think a pretty flat.
Pretty flat. How about omentum? I use omentum so much, and you can put it subcutaneously. It's a great bed of vasculature. It's inflammatory cells there, it heals, and you can do it through a defect in the diaphragm, relatively small, as long as you don't twist it. We use a lot of omentum. David and I use omentum for sternal reconstructions, and also to cover things like tracheal injuries, esophageal problems.
So I want to give our other presenters time. I'm just going to quickly run through a couple of points about this. Some of them we've already gone over. The most common primary chest wall malignancy is chondrosarcoma. It presents just like with this guy, slowly enlarging. They may have some pain, may not. Show the radiologic features are just what we saw, kind of a lobular, poorly defined mass with a lot of cortical destruction of rib and or sternum. 5th decade, slight male predominance, and again, very poorly responsive to chemo and radiation therapy. So there's really not a role for neoadjuvant therapy or anything like that with these. Surgical resection is kind of the only option for treating this. Best long-term survival up to 96% 10-year survival with an R0 resection with wide margins. As far as chest wall reconstruction, we reconstruct for any defect greater than 5 centimeters for sure. More than 3 or 4 ribs. Smaller defects, we have a lower threshold in the anterior chest wall. If you resect more than 1 rib on the anterior chest wall, then you need to reconstruct that some kind of way. And then the 4th to 6th ribs posterior. So we were talking about posterior sections. If you're up above the scapula, then the scapula covers a lot of that. You don't need to reconstruct that in a lot of cases unless you have several ribs. But those 4th to 6th ribs, the problem is the scapula can fall into that chest wall again and trap scapula, and that's a very unpleasant problem to deal with. So options, you can take a sheet of Gore-Tex and just sew that to the edges of your defect and leave it at that. It's very easy to do. That's the advantage. Prevents lung herniation, closes the defect. Doesn't restore any chest wall stability, so that's the downside. You lose chest wall stability, and that's just gone. So methyl methacrylate, used more commonly in the past. A little more difficult to use in some ways. You have to mix up a rosin in the operating room and create this mesh sandwich, and it gets really hot when you're doing that, so be careful with that. You can shape it to fit the contour of the chest wall, so that part of it's nice, and it does restore the rigidity of the chest wall, but in some cases, some people think it may be too much rigidity, especially the anterior chest wall. And so that's why some of us started using bridging plates instead, that we can restore the continuity and stability of the chest wall. But what we maintain that you don't really get as much of with methyl methacrylate is we have the intercostal motion that's preserved. So with respiration, you have that ability for the intercostal spaces to expand and come back together, whereas the methyl methacrylate kind of just cements everything in place. Disadvantages, you can fracture the plates. I've had a couple of plates actually fracture, and you can dislodge the plates. But overall, we have pretty good outcomes with these. And then generally, if you have a chest wall reconstruction, you end up needing some kind of soft tissue flap, and kind of went over that already. So, are there any other questions you would like to ask about this case?
But what is his 5-year survival?
So,
I know he's elderly.
Right.
He may die of other causes, but
sure,
we're from a neoplastic.
Right, if we pretend he's 60 years old, we have this posterior margin where there's tumor present there. If it was totally negative, then we could say he probably has potentially as much as 90% 10-year survival. I don't know what it would be with this posterior margin being positive, but still, I think likely pretty good.
Comment on that posterior margin. I think when pathology was grossing it, I think the pericardial fat fell off. And I think that, because they told me it was just a small area that was exposed, that was that area.
I see.
So
In that case,
true posterior exposed.
in that case, something else.
If he was 50 years old, you had that margin, would you re-resect or would you watch it?
I think I would still watch that. Yeah, I would watch
That's the right
that.
answer, don't you?
Yeah.
Thank you so much. One of our trauma surgeons just come back and join us this last year.
I didn't do it the slides quite as nice and stuff pretty well, but so this is a trauma case of a 47-year-old male. And we present. It's not showing it there. Oh, thank you. All right. So I'll do this. So it's a 47-year-old male who presented as a tier 1 trauma as an ED to ED transfer from an outside hospital. He rear-ended a car while driving a 3-wheeler slingshot motorcycle, which I was going to ask Dr. Griffin if he had a case like that before. But outside hospital CT scans, read as a liver laceration with hemoperitoneum, a splenic artery dissection, and a few rib fractures, and suspicion of bowel perforation. So he arrives, heart rate 110, blood pressure 140s over 80s, GCS 15. He had received some blood prior to arrival, but wasn't needing any blood after arrival. His FAST was positive, and he was reporting abdominal pain, was tender on exam. So we reviewed here's a picture of a slingshot motorcycle.
That's legal, huh?
Apparently. And hopefully this CT will work. But you can see a large liver laceration, hemoperitoneum. And slow down here around the duodenum. There's some dots of air around the duodenum. May be difficult on this granularity of the image, but there is some small dots of air throughout the upper abdomen as well that are free and can come back through the scan with a lung view that shows that more clearly. He does have some fluid in the pelvis as well. So let's say Dr. Brumley, what you gonna do? This is an easy one. I'm giving you the easy question.
Yeah, I mean,
Yeah, so with those there you can see right there, dots of free air, CT read saying possible valve perforation, tender exam, positive fast, require blood. Even though he's stable right now, even though he's GCS 15, you gotta explore this and rule out all of his injury. So, this is what we found. So this is the third portion of his duodenum. He had a large mesenteric defect in his transverse colon, so much so that we were concerned about that becoming ischemic, and the middle colic seemed to be involved. So we had to tie off a few vessels there, and we did resect the right colon, and that helped us to better expose the duodenum. And the third portion of the duodenum, these are not created by us, but two blunt trauma D3 injuries, perforations that we're showing here with the back pop. So you can see at least this more proximal one on the right side of the image is quite large. Seems to be more than 50% of the circumference of the duodenum, and there's a secondary injury in close proximity to it. There were no other small bowel injuries. We ran the small bowel. Obviously, he had the large liver laceration that we packed off, put hemostatic agents on. We were able to control that, and we left him in. Oh, let me just ask first before I say what we do. What would you do, Dr. Parrish?
He's stable at this point?
He's been stable since arrival.
And you said no other bowel injuries, spleen,
No other bowel injuries.
and the liver lac seems static.
Seems static. I believe he did get a product or two in the operating room, but no pressors, no MTP.
Obviously, you can't repair that primarily.
Really?
What it looks like.
I don't know if it's obvious. That is the typical recommendation nowadays, is to do less with duodenal injuries, which is part of why I was picking Dr. Griffin's brain of a different era, is that over time, we're doing less and less and less with duodenal injuries. There's no large RCTs that say what exactly we have to do with them, but in the general trend of all the prospective and retrospective studies we have is that less is more. The more you do, the more complicated it gets. But so we try very hard to primarily repair even something like this, potentially. However, I agree with you on this case. I was concerned about doing that with the proximity and the size of that proximal injury, and so I did not primarily repair it.
Did it bleed? Was it bleeding from the edges of the mucosa and everything?
Nope.
Because the dark nature
Yes.
of some of the edges.
Correct. Yeah, and you worry about that as well. So you don't want to try to repair it with malperfused or ischemic tissue. Yeah. So what would you do? I didn't let you answer. You just said what you wouldn't do. How about just give me some other options of things that people have done for duodenal injuries?
You could, the trauma whistle is an option.
Yeah.
You could, you would need to divert, so you could do a staple at the antrum and do a B2 if he was stable, but I wouldn't do it at this point.
Okay.
That might be a later discussion.
Yeah. So stapling at the antrum.
Or at the pylorus, or D1.
Okay, and then so you're saying repair it, staple at the antrum, and then do a B2. What are you hooking up to the stomach and that? You're repairing this.
No.
Okay, so you're resecting this, and then you're stapling the antrum too, because now you have the.
I would do one or the other.
Now the ampullus in a closed segment. If you staple the antrum and you resected this. Dr. Harrison?
So,
Looks like he wants to
very
answer.
complicated. You could resect it, and then you would have to do some form of like a Roux-en-Y type reconstruction, bring up some jejunum, and do a blood and jejunostomy to it. And then I would probably bring up another limb to the stomach, like a D2, and connecting that, so you kind of got a D2 connection at the gastric, a gastro-J, then you got a DJ, and then the Roux-en-Y connect down, and then I would probably do it. I would say I'd probably do it laudable exclusion, like a TX stapler, just proximal pylorus, so that like basically when that heals, you don't have.
So these are some of the things that have been described. So pyloric exclusion is where you either put suture or staple line across the antrum and then have some kind of drainage, through a GJ or something like that, or remove them. And then you have kind of what you were describing, which is repair them primarily, but then divert it with a B2 and put a tube in the duodenum, which is what's called a duodenal diverticulization. These are things that have been done in the past, right? And then there's a trauma Whipple, which is never recommended on the first surgery, but is an option for take-backs in certain cases. Usually that's more for associated pancreatic head injury, associated common bile duct injury, none of which this patient had. He had some mild contusion of the pancreas, but no obvious parenchymal disruption, no obvious ductal injury. So it's really just these two injuries that we saw. So what I elected to do is to resect it, as y'all said, and then do nothing. Put an Abtheron and come back another day to fight, right? So resected the D3 and I resected the colon and I left them in discontinuity and I put an Abtheron to get them fully resuscitated and come back another day for a definitive reconstruction. So we did that. This is what we just talked about. And that's what we just talked about. All right. So we did get an MRCP in the interim between the two cases to look at the pancreatic duct, to look at the common duct, to make sure there wasn't any injury there, and the radiologist did not feel like there was any pancreatic ductal or biliary disruption. So we came back for the second operation. SPY 5 was mentioned, you can't just leave D4 there. Free floating, you're going to have some way to reconstruct that, and so we did skeletonize out D4, and it becomes devascularized when you do that, so that's what you're looking at here. And we did use some SPY 5, and you can see with the pen there where we made our resection on unhealthy ileum. And then I elected to reconstruct that, so I did an anastomosis. I did a D2 to ileo primary anastomosis. I did side to side. And I felt pretty confident with that. I felt really good about it at the time. I think I was a little overconfident because I had recently had a little frail 86-year-old lady with a duodenal injury that I had repaired and did great. And so I was like, I'm on top of the world. I can handle this, Don't ever have that attitude. So hooked it together, and the SPY 5 looked very promising. The anastomosis looked great. I felt like this is going to fly. This is going to do well. We also did our ileocolic anastomosis, which you can see there. So post-op, of course, the patient actually did very well. He was extubated in the operating room. He was, up and talking and in the chair. He was passing gas on post-op day, I think 1. On post-op day, or by post-op day 3, he was passing gas. We did elect to give him some clears. Now, some people would keep these people NPO for, weeks and put them on TPN and things like that. From my reading of the literature, any nutrition is going to help that to heal, and that is a critical decision point that we didn't talk about, is that I did not put a feeding jejunostomy in this patient, which may have been the right thing to do, but I felt so confident at the time that I thought about it, and I didn't do it, and so here we are. So post-op day 4, he had a bowel movement, he had some increased pain, and his heart rate went up to the 140s, exactly what every surgeon wants to see in this situation. And so we made him NPO. We gave him some parenteral nutrition. But despite those findings, he was having an improving leukocytosis, actually normalized. It was white count of 6. His liver enzymes were all downtrending. He did have one episode of emesis on post-op day 6. But then by post-op day 7, he had persistent tachycardia, worsening abdominal distension. A CT was obtained. It was a Saturday. I wasn't in the hospital, but here's the CT. We did leave some drains. I didn't mention that, but I always want to do that for any kind of pancreas or duodenal and also liver. So it's got some free fluid. He's got this large fluid collection behind the stomach here. Some dots of air around. He is post-op day 7, so it's not completely out of the realm of possibility. This is all just operatively related, but it certainly doesn't give you the warm and fuzzies. Looking at the anastomosis right there, there's contrast going through it. There's no contrast spilling out into this fluid collection, so they don't call a leak. So I felt good about the results of that. The contrast is going through, the contrast isn't coming out into it. So we asked IR to put a drain into some of this fluid. Oh, I should have asked what you would do. So we asked IR to put a drain into some of this fluid. So this is how they read it. Fluid collection and between the gastric wall and pancreas, likely in lesser sac. So here we go. What would you do, Dr. King? Yeah, would you take the patient back, or would you place an IR during day 7? So it's kind of like getting to your last opportunity to take it back, but he's got abdominal extension, he's got persistent tachycardia, he's got dots of air around there, his white count's normal.
You can step this up to the hepatobiliary surgeon.
Yes.
too.
Yeah, okay. Dr. O'Leary, help me. I'm trying to help this patient. What did I do wrong?
If you have a drain there, I will measure the amylase in the lesser sac to see if even though you did not see any initial disruption of the parenchyma of the pancreas or ductal disruption, but it could be there, but you did not see it. So you measure. If there is a leak, you will check the drain there, and if it is not major, it will get better by itself. If it is a major, you have to do something. But it will not stop. You do not have access to ampulla, so you cannot do ERCP to the center. So these are the problems that we are going to face.
Yeah, in his case,
the
they...
is to measure the amylase to see if it's leaking or not.
You're making me feel better. That's what we did. So we put a drain and we got amylase. But he does have access to his ampulla because we did not do a pyloric exclusion. We did not, no.
Okay.
We did a primary anastomosis. So there is access to the ampulla.
Yeah.
So our two IR drains were placed. Rust-colored serous fluid, not poop, came out. And drain amylase was 1,582. So there you go. So we kept him in PO, we kept him on TPN. In the next 4 days, he continued to look good, but 2 weeks out, had this partial fascial dehiscence. Wound looks like this now. So now, let's ask somebody else who hasn't answered. Dr. Chen, what you gonna do now?
So it looks like there's no, so you can see the PDX
You can almost kind of see even a hole in the fascia there.
and everything's disabled. I mean, I took care of this patient at night, so I know that you guys basically placed a wound back on top, or did local wound care thing at that time, kind of watched it. But I wasn't sure if there was any fluid that was coming out. Was there?
Yeah, so I don't disagree with placing one back, but I'm going to exercise extreme caution to not put a black sponge directly on this. That's a terrible idea. Okay, so the recommendation was to cover all the fascia with white sponge, and then help us quantify the output, because there was some serious output coming out of this. To cover everything with white sponge and put a black sponge on top of that. But you're right. At first we did wet to dries. Once we were confident that it wasn't changing, we put a white sponge, black sponge on top of it. However, at some point, the white sponge was not placed by whoever was changing the back. I think it was a wound care person, but that's a big oopsies. And then bleeding came from this partial dehiscence, some major bleeding, which I don't think was related to the black sponge, but certainly the black sponge didn't help anything. So post-up day 14, the same night of that partial fascial dehiscence, he started having, I think Dr. Chapman, you were on, he had some significant bleeding coming through the partial dehiscence. Blood was coming out of the wound. So he's taken, resuscitated and taken the CT. And this is the CT now, 2 weeks after his operation. 2 weeks after his second operation. So this is just a mess. There's still air, there shouldn't be, there's fluid everywhere. You can see right there, big contrast. Something's bleeding in there. There's some badness, there's a lot of fluid, there's a lot of air. But we know now he does have a connection to the outside world, so maybe some of that air is related to that. It's all blood that's coming out, not poop. So he gets taken to, I guess, let me kick it back to Dr. Dom. What would you do with that CT scan now? 2 weeks in, there's air and fluid everywhere, there's a bunch of blood, you're having to give him blood products.
So active bleeding, I would have IR take a look at the film to see if they do well.
You wouldn't take him back to the operating room? So 14 days you're kind of pushing it, right? But I don't think he's been doing a whole lot of healing either, so I think it is an option. It's just a really miserable one. But it is an option to try to take this back to the operating room at this point with those kind of findings. But you're right, that's you don't want to do that. And what did end up happening is they took him to IR, and IR did a SMA catheterization Did I go over time? I'm so sorry.
No, please, no, we're good.
And they did embolize a branch of the SMA. It's a little difficult to see here, but you can see they're coiling right there. It's a little difficult on the original to see really any contrast extravasation. I have a hard time seeing.
Is that a jejunal branch?
It's the second branch of the SMA is what they call, Okay, so basically, cat was out of the bag when this event happened. And as you can see, there's air and fluid everywhere. The partial dehiscence had bleeding coming out of it, became a full dehiscence. There's now bilious output coming out, and it develops into this interoatmospheric fistula. So, what are you going to do with this? Dr. Holland said. Cry a little bit, and then how can you do that? What do you mean by local wound care and quantify? The nurses looking at you like, what are you talking about? I don't know how to do that.
Make your oral board seem very easy after this question.
Yeah, so we put a wound manager on. You know what a wound manager is? Okay. Yeah, so it basically keeps the moisture in, keeps the fluid in, helps you quantify the output, but essentially that progressed into interatmospheric fistula. At some point between that initial image and this image, an ERCP was performed. I wasn't aware that was going on, and I don't know if that had anything to do with it progressing, because when they put the scope in, they said that they couldn't see where they were, as if there was a full transection of the duodenum. So this is just an unmitigated disaster at this point. Nicest patient in the world, of course. Did very well with parenteral nutrition. We tried to limit the output as much as possible, but when you're in the duodenum, there's not a whole lot that loperamide or Lomotil or any of that kind of stuff is going to do. We had him on IV PPI, of course, but nothing's really going to mitigate that. You just have to keep up with the output that he's putting out. And so he stayed in the hospital for another about 7 weeks, was able to be discharged to an LTAC. The wound had closed significantly, or had decreased in size significantly at that point, and the output had decreased significantly, but it was still high, still greater than a liter, closer to 1.5 liters. And I have not seen him yet in follow-up. So I don't know if he's passed or doing well and hasn't shown up or is still in LTAC or what, but hoping Dr. Griffin could tell us from his experience.
How long has it been since you've seen him now? Is it 6
It's
months?
been, it's been a couple months now.
Well,
Yes, sir, Dr. Amiri. I'd love to get Dr. Amiri and Dr. Zafari's opinion.
I can give some comments. Is the pancreatic problem that if one pays a little bit more attention, you will find it in the operating room the first time. And that's the golden time that you can manage. If it's very distal, you can do distal pancreatectomy and don't worry about it. If it's the middle, you want to preserve both sides. You will close the proximal resection area or damaged area and invaginate the distal part either into the stomach or into the bowel, jejunum, whatever is more easy for you. So you can keep the function of endocrine and exocrine function of both limbs intact, and that will solve the problem. Now, in cases like this that you did not have pyloric exclusion, I don't know why they did not put pancreatic stent in this patient, but that will decrease the pressure in the pancreatic duct and will ease the leak. Because still you have a lot of leak, and that's causing the problem. So you have to decrease the pressure in the duct in the pancreas to help yourself.
You ever seen any lethal bleeding from a fistula, like from?
Yes, the danger is the bleeding. The fistula will finally heal. But if the fistula and the enzymes go around the vessel and erode the vessel, it's terribly a difficult situation and can be lethal. And kill the patient, and they cannot manage IR or the surgery, you cannot manage it, and the patient will die.
This is a classic abscess World War scenario, right? The Herald leak from pancreatic leak, right? It's usually post-op whipple or something like that, where you have a leak and you have this like little bit of blood in your drain, and they're fine, and they just exsanguinate to death, right? So thankfully, they called right away on this, and we were at the bedside.
Was it pretty dramatic bleeding, Griffin?
What's that?
Was it dramatic?
quite significant, yeah. To the point where I have a rule of I yell 3 times a year or less, and I yelled that night to get IR in the hospital. So, yeah, that was significant. Connor, the MRCP that you got between the first and second operation was negative for a leak, correct?
Correct.
It was kind of a subclinical.
And I did look at the pancreas in the original operation. All I saw was a little bit of bruise, like very mild bruising. I didn't see any parenchymal disruption or ductal disruption. Now, the duodenum that we resected did come off a portion of the inferior portion of the head, an incident process, but I didn't see any active leaking or bleeding from there at the time of the resection. But Dr. Zabari, educate me, please.
Well, congratulations again. I think these are really difficult injuries. And by all means, I'm personally very conservative when we do injury. 2 things. I always do the best I can to do priority exclusion. Second thing that, I will not feed these patients very early. If I'm going to do it, I always do that for GI just to be safe side before I will start feeding these patients. This stuff I must know, I'm not worried about. I do believe that early feeding is important with chronic and this is not small valve, but duodenum has a very high traffic area, and any compromise, especially when in emergency and stabilize with back. So I commend you for all of that stuff. I think done perfectly well. We have time for familiar polyposis. We do total duodenectomy and create a new duodenum without actually doing pancreatic resection. And I do agree with the sentinel bleed, especially post-Whipple. If you don't address it, in the court of law, you will lose the battle. No questions asked about it. And sometimes majority of time is from gastroduodenal and the Whipple procedure. Here, obviously, had big trauma. And we have had cases at this institution where we have reported 6, 7 cases with pancreatic duct disruption, conservative management, they fully recover without anything done about it. So I would leave it drain in the proximal pancreas. I would not do invagination of the stomach or jejunum, trying to minimize less anosmosis. I think it's better. You can always go back in a later date at this pancreatic duct. If not. And second thing, I would not done ERCP. I'm very, very nervous having a fresh anosmosis with ERCP and bleeding and everything else. Majority of the time they do endoscopy, they can't see nothing at all. So you poking, pushing, probably that led to a bigger preparation rather than a smaller one. But IR, it was the right thing to do to get embolized control, because majority of the time, by the time you get there, you may lose your patient.
And just to summarize for the residents too, I think that's what I would have changed about this case is, like I said, the literature is pointing towards less is more, yes. If you can repair it, do that. But if you have a complex injury, what I mean by complex, I mean if you're having to resect a portion of the duodenum, I would do, in those cases, a pyloric exclusion or some kind of drainage procedure from now on. So from now on, if I'm resecting the duodenum, I'm definitely going to do that instead. And then I'll also put a feeding J. So that's what I would change about my management in this.
Thank you. That's very
I didn't expect the complexity of some of these, but I will tell you that's where everybody's involved. And I would like to say Dr. Zabari has basically revolutionized the way we treat injuries in Northwest, not just Northwest Louisiana, but the entire region of about 1 million patients that we have access to. So, Ghazi, thank you. You really revolutionized hepatobiliary surgery here, and you've taken it to such a high level. Your expertise is really appreciated. Patients appreciate you.
It's good to the entire team.
Absolutely. Dr. Keller, last case.
Okay, this is a case that I shared with Dr. Lamb. I have no disclosures. So this is a 49-year-old female who presented to our clinic with an enlarging raised pigmented skin lesion on her back. This was initially noted about a year prior, but recently over the past several months, she noticed episodes of bleeding. No significant past medical surgical history aside from active pack-a-day smoker. Physical exam did reveal a palpable left axillary lymphadenopathy. what would you guys do next? Interns, shout out. Punch biopsy, correct. We got a punch biopsy that we did in clinic. I think you did that actually. Which revealed nodular melanoma. The depth was at least 3.2 millimeters, 6 millimeter square mitoses, Clark level 4, clinically staged at least T3A with the clinical node positive, and this is classified as clinical stage 3 melanoma. All right, so what would you guys do next after this? So you have a 49-year-old female, nodular melanoma of the back, at least 3.2 millimeters thick, on biopsy, and clinically palpable left axillary lymphadenopathy. She's at least stage 3 clinically at this point. Thinking about cancer in general, what would you want to do? You name it, then you do something else, and then you do something else. Staging. Okay, what would you want to do for staging?
CT, chest, abdomen, pelvis, and then
MRI brain, yes, but you can do CT, chest, abdomen, pelvis, but I think what's better for melanoma is a whole body PET CT, because that includes the skin of the entire body. So going through NCCN guidelines, these are frequently updated, which is excellent, reflecting recent trials. So stage 3 clinically node positive melanoma, you want to obtain a biopsy and obtain baseline staging imaging. And principles of imaging per NCCN and just in general, you can do a baseline nodal basin ultrasound, whole body PET CT, and brain MRI to look for metastasis. All right, and so we obtained a whole body PET CT and a brain MRI, which we have here. Brain MRI was negative, and a whole body PET CT, you can see FDG avid left axillary lymphadenopathy, and then the back lesion there, no other sites. All right. All right, what would you do now? So she's clinically stage 3, no evidence of distant metastasis. What is your next step? Let's do second year. Chief?
When you get last year, I would present her
Yeah. Exactly. Present her in a multidisciplinary tumor board, which we did. And yes, typically you do prove the metastasis with a corneal biopsy or of the lymphadenopathy, but I think in this case, we just wanted to rush to treat her. So looking at the NCCN guidelines, neoadjuvant therapy is the preferred management, and the reason for that is a couple pivotal trials that were recently published, which I'll go into. The rationale for neoadjuvant immunotherapy in the setting of locally advanced melanoma is that with neoadjuvant therapy, the thought is that you can activate T cells that are specific to tumor-specific antigens, as opposed to in the adjuvant setting, the tumor is gone, and so you're activating T cells directed to non-tumor specific antigens. The tumor is gone, so how can you see tumor-specific antigens? So that's the thinking behind why these trials we're looking into a role for neoadjuvant immunotherapy. One of these two trials, published in 2023, is the SWOG 1801, the phase 2 randomized controlled trial. They included patients with both stage 3 and stage 4 melanoma, so it's a little bit of a mixed cohort. They grouped patients into either neoadjuvant immunotherapy or surgery followed by adjuvant. Their neoadjuvant immunotherapy protocol was with a single agent anti-PD-1, given for 3 cycles followed by surgery, and then adjuvant anti-PD-1 for a combined total of a year of the immunotherapy. And in the surgery group, those patients just received adjuvant anti-PD-1 for 1 year. And what they found was significantly improved event-free survival at 2 years, 72% in the neoadjuvant group versus 49% in the surgery group. And then more recently, in 2024, the NADINA trial, which is now phase 3, randomized control, they looked specifically at stage 3 clinically node-positive melanoma patients. So this cohort is excluding metastatic melanoma patients, grouped into either neoadjuvant immunotherapy with dual anti-CTLA-4 and anti-PD-1 immunotherapy for 2 cycles, followed by surgery, or surgery followed by just adjuvant immunotherapy or tyrosine kinase therapy, depending. The interesting part about this trial is that they assessed, in the neoadjuvant group, they assessed response and used the patient's pathologic response to dictate whether or not to give the patient's adjuvant therapy. So those who underwent neoadjuvant dual immunotherapy, who had a complete pathologic response, did not receive any adjuvant therapy after surgery. And then those who had a partial response received adjuvant single-agent anti-PD-1 immunotherapy or one of the tyrosine kinase inhibitors. And what they found was an even higher statistically significant event-free survival rate at 1 year of 84% in the neoadjuvant group compared to the surgery and adjuvant group. So that was the rationale for our decision to then proceed with 2 cycles of the dual anti-PD-1, anti-CTLA-4 immunotherapy for this patient, and then underwent wide local excision, in addition to a therapeutic left axillary lymph node dissection. And just as a segue to ask more of a simple question, what kind of margins would you guys get for these different thicknesses? It's actually a lot easier to remember if you quickly go through. Dominic? I'm just calling on you because
Inside 2, 1 centimeter, depending on the depth, the 1 centimeter or 1 millimeter, you have to go up to 1 centimeter.
Yep. Yeah, so I think about it as inside 2.5, 1, 1, 1 to 2, 1 to 2, greater than 2, 2. That's it, easier than that. Interestingly, we do have an upcoming trial, the Melmark trial, which is looking at this intermediate thickness group, the 1 to 2 and 2 to 4, and comparing 1 centimeter margins versus 2 centimeter margins and seeing if there are different outcomes. So that should be coming up soon. I say soon. Soon is probably several years, but we'll see. All right. So for this patient, interestingly, she had a complete pathologic response, both in the primary melanoma and the lymph nodes, which is amazing. So what do you want to do next? So NCCN lists all the different options. They give you every potential option, and then they have you kind of discuss it and do patient-directed. Systemic therapy, radiation or observation. So what's the, I guess, rationale for, let's see, what's the rationale for potentially observing or giving any adjuvant therapy? So going back to the NADINA trial, the patients who underwent neoadjuvant ipi-nivo, about 46% of them had a complete pathologic response. That's a high percentage. And over 50% had a major pathologic response. So and remember I said that the adjuvant therapy for these patients was response driven. So in the group that had the major pathologic response, which was about 57% of those patients who underwent neoadjuvant ipi-nivo, they then did not receive any adjuvant therapy, and their recurrence-free survival at 12 months was 95%. So that's pretty amazing. That's that top green line up there. And then those with partial pathologic or no pathologic response, they all received some form of adjuvant therapy. And you can see that their 12-month recurrence-free survival is lower. So this provided the rationale for giving these patients for not giving, for active surveillance, for no adjuvant therapy for these patients. So that's pretty amazing. And then on our discussion, the only caveat with this I would say is that, we don't have long-term data yet for these patients that we're watching without adjuvant therapy who only received, 2 cycles of Ipi/Nivo. But it's reasonable to just actively survey based off of that trial. So that's what we're doing for this patient. And then active surveillance, what is that? Well, that's frequent full body skin exams, alternating it with dermatology, frequent, and then intervals of repeat baseline staging, mostly just whole body PET CT scans. The NCCN guidelines give you kind of a big range, every 3 months or 12 months or 2 years. Usually the first 5 years is more frequent and then thereafter you can do more annual. All right, that's all I have. Any questions?
Immunotherapy's taken off over the last decade, and it's changed the way we treat a combination of screening, early detection, immunotherapy, and then the traditional either neoadjuvant or post-operative adjuvant therapy. Is there any way, and I'm asking this to anybody in the audience, if there's any predictability, because the papers are all over the place about when immunotherapy, how long immunotherapy, and what stage. Is there any predictability from a neoplastic or from an oncologic viewpoint on how you can predict how effective immunotherapy is going to be?
Well, I really appreciate Dr. Keller summarizing the trials and participating in this case. It's really remarkable. I mean, if you saw that clinical picture of what the tumor looked like, and this patient had a complete pathologic response. There was no viable tumor in the lymph nodes or the tumor. So I don't know about how to do that.
We don't either in the thoracic literature. It's kind of a shotgun approach. We're finding now through these trials like this on how to better predict, and I think that's the only way is try to put them in randomized prospective trials and to see what the effects are. It seems rather random, but I have to really depend on my medical oncologist to say, okay, this is what not only the literature shows, and this is a person I would put on there. So as a surgeon, I feel somewhat, I used to know that literature and can direct myself on people that needed neoadjuvant, but I'm truly at the realm of these prospective trials. And I think it's going to further elucidate where we treat people with immunity. But it's making a difference. Lung cancer rates have dropped dramatically. Yeah.
So for breast cancer, I think the response to immunotherapy, our HER2 positive tumors have extremely high rates of complete response, almost 90%, and the triple negatives are next to that. It drops off a little bit with HR positive, so we know just from the subtype, but then also predicting the response and the benefit of the adjuvant of chemotherapy in general. Chemotherapy is the genomic testing, and it's testing not the patient's genetics, but the tumor genes to actually give a predictive response of who stands to benefit.
Yeah, breast cancer leads the way in tumor markers and predictability. I think genetics, it also plays into the role maybe in some of the declining cancers and predisposed people that have early colon cancer.
Is there any new updates on the idea of doing vaccines for melanoma, like personalized, that individual patient? They talked about that before, but I don't know if there's anything new.
I think from what I've seen so far, we moved away from that. I know they're looking, there were some where they were kind of looking at creating personalized melanoma vaccines, but then giving them in addition to either immunotherapy or like TVAC or something like that. Yeah, I know in terms of like TILs and like Liflacell and kind of creating personalized, not necessarily vaccine, but activated T cells, your own autologous activated T cells to tumor. But that's, again, specific to, they have to have a specific tumor burden of metastatic disease and then be able to tolerate receiving the IL-2 therapy and being in the ICU and all that stuff. So in that respect maybe, but in terms of going back to the personalized vaccines, I haven't really seen much out there. But I will say, in terms of neoadjuvant therapy for all like GI and colorectal cancers, what we're finding, at least in colorectal and even gastric, I think too, I think this may also include esophageal, but adenocarcinomas that are mismatch repair deficient respond extremely well. They have a high response rate to immunotherapy, and just immunotherapy alone. You can get colorectal patients with mismatch repair deficient tumors almost like 100% complete path response, or complete, well, not path, but clinical response, and then you're doing watch and wait for those patients and just clinically following them. However, the proportion of patients with mismatch repair deficiency is kind of low. It's like less than 10%. So, maybe 10% of all patients will have mismatch repair deficiency and be able to respond, almost 100% response rate to immunotherapy in the neoadjuvant setting. But yeah, and we're using it as an adjunct for neoadjuvant systemic therapy for gastric patients and gastric cancer patients, and they're having a remarkable tumor response, and their overall survival is increased. We're applying that to distal esophageal patients as well. So yeah, we're using it pretty much for every tumor space. Yeah, no, it's not. Yeah, but we're just learning more and more about it as we go. Yeah.
Well, thank you so much. Those were superb presentations by our faculty. I'm amazed at what we have in our department. And we're going to transition now. Dr. Brett Chapman, our Chief of Trauma, is going to transition us into the surgical Jeopardy, which is really fun. This has been real academic and stoic, but we're going to move something in that's a little bit fun. I'll let Brett kind of explain surgical Jeopardy, maybe when it kind of started and how we've used it as a learning tool.
Yeah, this, for me, this just started as a whim too late at night where I started watching YouTube videos for how to animate a PowerPoint to make a Jeopardy form. And then because I spent so much time on it, I just kept doing it because I'd already invested hours and hours. So, the teams are going to sit back here at the table. Jenny's going to be my buzzer manager. So while they're getting situated, I'll just, I guess, kind of explain. So we'll have the board up here shortly, and our buzzer is going to be through their phones. That way there's no debate as to who buzzed first. It'll be, Jay will be able to see it, turn it off and on, reset it, things like that. One of my biggest pet peeves is the button mashers who mash the button and hear the rest of the questions and answers. It's kind of a way to cheat. So to fix that, the slides are animated to where once they hit the button of the question, the slide is blank, I'll read it. And if they mash before the question is finished being read, then they can find the answer based on that. They won't see the question. So we're going to try to keep it authentic and have a little bit of fun. So I'll just go through the categories while we wait and they get set up. So a brief history of sleep deprivation. This is a kind of history of surgical residency in general. Titans of the Table is a Legends of Surgery kind of category. Made in Shreveport is about this program here. So it's some kind of facts about the residency, the department, kind of together. Then and Now is like a Name That Chief style. So there'll be some pictures and some facts, and you'll have to guess who we're talking about. And then the last two, Famous Last Words and More Famous Last Words, was, I think the residents were excited about this one. This is a faculty quotes. So you'll have to name that faculty by some of their common isms. So I left out some of the more colorful ones to be PC. Should be fun. All right. They're getting situated with the buzzers back there, and we'll get started as soon as they're ready. And we'll be able to keep score right here on the screen too. So. What's that? There should be PGY 1s, 2s, 3s, and 4s. So who missing?
Yeah, they forfeit.
Where are they at?
I don't know. I think two of them are huge.
I think they ran about together. I don't know. Matt might, did y'all get in?
Matt, take over.
Are y'all in? Matt, come.
I think so.
Are y'all in?
It's probably a disadvantage because he doesn't want Sure. Go Pete, you're good.
Yeah.
We'll try to make up some schedules. been sipping my drink slowly.
CCG got buzzed. Yeah, sorry. This was backed up.
Should I let the interns go first or the fours? What do y'all think? Closest to graduation or?
CCG got buzzed.
Okay. Yeah, these aren't the classic like AppSite medical knowledge trivia, so I think the parody should be good. We should have a pretty good chance of anybody winning if they pay attention.
Okay, XR, 9 tar. And then you can just repeat it as your name.
All right, you ready? Did y'all all buzz in?
Do you want me to come?
Have y'all all test buzzed? Y'all all buzz once. All right.
I got it.
All right, we're good. We said it, and we'll let the interns.
After you vote. Hey, we're going first.
All right, y'all ready? Dr. Darvish and Dr. Lincoln. Your pick.
Famous last words for 300.
Famous last words for 300. I have to go over here. It's going to be a little bit disorienting. All right, this is a good one to start. Wasteful Americans.
Did you want floors?
Who is Dr. Bar?
That's correct. All right. It should. Oh no, it's not working. Oh, tragic. All right, let me get a sheet of paper. Someone have a pen and a sheet of paper?
There's whiteboard.
Actually, we need to.
Yeah.
This must be it worked on my laptop, getting it over to this computer must have. Apologies. I just need a pen. I can keep scores. Oh, all right.
Oh, there we go.
Oh, perfect. We'll do it up there. All right, 300 for the PG White Horse. All right.
Famous last words 400.
Famous last words for 400. You just gotta beep, 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 then it's done. They're yours. Dr. Who?
Who is Dr. Reinhardt?
That's correct. It's 400 for the week, right? You said it's legally. All right, they're yours.
More sound effects than actual words.
I'm sorry. I can't have y'all come do it exactly. I'm just doing my best imitation. If I called you up here.
Famous last words, 200.
Famous last words for 200. Here I come. Here I come.
Threes.
They're yours.
Who is Dr. Blaine?
That's correct. 200 for the third years. Correct. All right. Let's keep it going.
Famous last words, 100.
Famous last words for 100. Oh, why don't you like me? Interns?
Who is Dr. Bird? What?
That's right. We're gonna get all these right. This is for,
Famous last words 500.
500? I'll let you do it. I just want to show you how I do it, but I'll let you do it. Second years.
Like shit.
That's all right.
Made in Shreveport 200.
Made in Shreveport for 200. This number of current Department of Surgery faculty members completed their training at LSU, Shreveport. I'll give y'all like a minute to do the math. I'm gonna count in your head for a bit. Should have put the Jeopardy sound effect in there.
He's missing it.
Got some intense discussions going on right there. They're trying. Some of these are going to have to wait for a minute. All right. 10, 9, 8, 7.
Once.
Interns?
What is 8?
8? That is incorrect.
Threes.
What is 9?
That is incorrect. Yeah. 200 minus 200 for
Ones and threes.
ones and threes.
Fours.
I like that answer. That's good.
What is 12?
That's incorrect. Well, they're missing people.
Twos, would you like a shot?
No.
We'll take the net advantage.
Can we buzz again?
What is 16? Would you like me to list them?
Yes.
Dr. Sugar, Dr. White, Dr. Pennywell, Dr. Richardson, Dr. Sitt, Dr. Savoy, Dr. Brown, Searles, and Boykin, Dr. McDaniel, Burkowski, Satig, Allie, Rhymes, Zizai, and Zavar.
We didn't count Monroe.
Huh? Of course we do. You're faculty.
I know, we forgot to count.
I actually walked all of the flags. It took me like an hour to make sure I didn't miss anyone. He didn't train here, did he? He's not up there.
Oh, no, you're right.
He's not up there. All right. Who was it? I forget. Seconders?
Second.
Yeah. Your board? You're no longer going to go away from that
Brief
category.
history of sleep deprivation, 200.
200. All right. Residents were given their name because early trainees did this.
Twos.
What did you sleep at the hospital?
That's correct. Live in the hospital. They didn't sleep much. So they say. So they say. All right, second years.
Brief history of sleep deprivation for 300.
300. Y'all love to go out of order. This surgeon, known as the father of modern surgical residency, and developed the pyramidal training model at Johns Hopkins. At least 2 of the 3 names. Might have made y'all with that too.
Fours.
Who's Dr. Halstead?
I guess I'll take it. That's correct. All right. 4th years.
History of sleep deprivation, 400.
400. Halstead's residency model was heavily influenced by the surgical training system he observed while studying in this European country.
Ones.
What is Britain?
That's incorrect. Anybody?
Anybody else popped up?
Addition by subtraction. That's what they're doing. No takers? All right, what is Germany? Y'all were like a few hundred miles away. Not bad. All right, 4th years?
History of sleep deprivation, 500.
Oh, this is the hardest one in the game. Just kidding. The death of this 18-year-old patient in 1984 ultimately led to reforms limiting resident work hours in New York and later nationwide. That probably is the hardest one. Famous case. Worth knowing. No? Dr. Richardson wants to answer. No one? Dr. Richardson? Yeah. Who was Libby's eye? Y'all should look into it. All right. 4 years again.
We'll do sleep deprivation for 100.
Clear it off the board.
Yeah.
That's good. This institution is widely credited with establishing the first modern residency training system in the United States in 1889. I went out of order, so you should know this one.
Twos.
What is Johns Hopkins?
That is correct. Do you know who established the first medical residency program, also at Hopkins? 100 bonus points if anyone knows it. The first medical residency was also at Hopkins. By another name you know, probably. Dr. Gray knows it. 100 points to Dr. Gray. Sir William Osler. All right, who had it? Your board. Where are we going?
Fours.
Then and now, 100 too.
Which one?
Then and now, 100.
For 100?
100.
All right. This chief worked for a tissue procurement organization during college and enjoys cooking meals from scratch.
Interns.
Who is Andre Romo?
Wow, didn't even make the photo. If you wait long enough, the picture will show up. That's correct. Hang on.
You could.
It's set on a 10-second timer. There it is. Right?
So I buzzed it over. We get to see it.
That's correct. All right, this is good. I didn't know if I was going to do it based on the facts. This is good. The pictures were like a extra hint for y'all.
Then and now for 400.
Then and now for 400. All right. This chief has been bitten by 2 snakes and has eaten fried roach, live worms, crickets, and maggots. This one should be second yours.
Samuel Pears?
I know they're chiefs. This is good. You can see it, right? There were a few that were like a little older and they were too obvious. There's one of Harrison like fishing, and I'm like, that looks just like you. Like 6 or 7. I'll pick the other ones. All right. Keep it going.
Then and now 300.
All right, then and now for 300. This chief rocks SpongeBob SquarePants glow-in-the-dark glasses and can throw a knuckleball.
That's the intern.
It's Dr. King.
That's correct. I'm surprised. I really thought y'all were going to have to wait for the pictures on all of these. Did y'all say? I usually get 1 mulligan.
That was our one. They got
That was your 1 mulligan.
All right.
We were so excited.
For not answering the form of a question. Any rigid today. All right.
All right.
Then and now 500.
Then and now for 500. This chief has been to Japan 3 times and still can't speak Japanese and hails from the fraud capital of the world.
Fours.
Who is?
The trust player.
That is correct. Wait, for 500.
500 for the fours.
The trophy's 3 times taller than she is. I wanted to crop it, but I was like, it would ruin the picture. All right.
Then and now for 200.
All right, then now for 200. If y'all can count, I'll figure this one out. This chief hates horror movies, but bakes cookies every week. So
Fours.
Who is Harrison Gray?
That's true. Harrison Gray, correct.
And that was
The 4 years. For 200. All right. 4 years.
Titans of the table 300.
Tied to the table for 300. Known as the father of modern neurosurgery, this surgeon trained under Halsted and described the disease that now bears his name. These are like very large, obvious names. These aren't trick questions. No one?
No one.
No history nerds? Come on. I gotta read some more.
Oh, threes.
Who's Dr. Huntington?
That's incorrect. Dr.
Mine's
Sabine
300
knows.
for threes. Fours.
Who is Dr. Griffin?
That's correct. All right. There's still hope yet. It was already good.
I didn't want anyone else to feel it.
Yeah. He was just waiting. 4 years?
Titans of the table 400.
Titans for 400. Oh, hang on. Hang on. I can't go back. Everyone, which one did I pick?
400.
400.
No.
We'll take it.
All right. Apologies. Looking over my shoulder got me. Oh, yeah, that's right. That's right. Thanks. I'm just waiting for y'all. Y'all don't know the answer. The General Surgery Residency Program has graduated chief residents in this many classes since its affiliation with LSU. Closest without going over. So if you've ever looked at those frames on the wall, you'll know the answer to this one. Gotta put some probably end up checking all of them. That means like absolutely not answering this.
How does it close without going over?
Turn the phone.
One person buzzes in. Can we just say 0?
Well, I mean, if only one person answers, you get it right, right? The risk is if a second person chimes in, outbids you. Yeah, so it's worth the risk. Come on, you can get a free 400 points. Do the countdown, 10, 9, no takers.
Greece.
30 years? 52. What is 52? You have busted. That is incorrect. Yeah.
Interns.
What is 45?
Okay. Anyone else?
Oh, twos.
What is 46?
All right. Any last minute takers?
You haven't buzzed. There's a great option for 47.
Four.
What is 47?
Probably should have handled this question differently. That wasn't the most fair. Yeah, 4th years. What is 48? Perks of being near Chiefs. All right, I'll read the next one. All right, Chiefs.
Did the other ones get negative points?
Yeah, technically, I guess. They could have been quiet. Just speak up and play the game, right? All right. Rising Chiefs. Your board.
Made it Shreveport 300.
All right, look the right one this time. All right. Number of department chairs with a portrait. Y'all walk by them every day? This one is not without busting. I mean, an answer. Anyone?
Nope.
I heard something, didn't
That didn't come up.
We'll refresh.
Okay, hang on, I'm refreshing
4th years,
again.
since you buzzed, it looks
Yes, four.
puzzled.
What is 4?
That is incorrect.
Oh,
That was
That
a
was
300 point
300.
question.
Anyone else? Come on, guys, y'all walk by 'em all the time. Threes.
What is 5?
That's incorrect. White is shaking his head. Y'all are so in trouble. Y'all are so in trouble. There's more that didn't have a portrait. That's why I made the question this way, so there was a verifiable correct answer. Limit the damage. Y'all want a shot, Don? I saw you reaching for the phone. All right. What is 8? Dr. Hurd, Dr. Abramson, Dr. Black, Dr. Knight, Dr. Kurtzwig, Dr. McDonald, Turnage, and Lee. I gotta pay attention to your surroundings. All right. 4th years?
Made it Shreveport 100.
Made it Shreveport for 100. They'll like give us the easy one. Current faculty member with the longest affiliation with the Department of Surgery. It's a tie.
Threes. Threes?
We're still discussing it.
Who's Dr.
That's incorrect.
Ones.
Who is Dr. Stig?
That's correct. Who is tied with? Dr. Allen. If I'm wrong, y'all, I'm pretty sure.
You beat her by a year.
Hey, that's
But I
not
thought
fair
you were away
question.
for a year and came back. No? Okay, well then it's Dr. Satiq, so you had it right.
Actually, Dr.
What about Dr.
I use the portraits as my guide, so if I'm wrong, it's certainly possible that I was wrong. Please correct me. All right?
Made in Shreveport 500.
All right, go for the big one. This many chief residents have graduated from the residency program since its affiliation with LSU. So the total number of frames on the wall. Closest without going over. Let's play the game again.
You gotta have to include the 5 new ones.
I don't know when they officially, is it graduation tonight? Is it at the end of this morning?
Not perfect.
I mean, I can make the number correct, because I know how many, yeah.
With actual graduation,
Yeah.
right, -5.
It'll be the answer plus 5.
Yeah. We're not.
I'm not gonna say anything. Anyone who answers can answer. I'm not gonna give any hints and mess it up like last time. No one wants to take it off? They're like they're holding fast together, solidarity over there. All right, what is 216? There's more. Dr. White will give us the bigger number with more historical context. All right. It was interns.
We'll do more famous last words, 200.
More famous last words. 1 foot on the grave, 1 foot on the banana peel.
Interns.
Who is Dr. Rao?
That's good. Should have done 6 categories of less.
Damn if you do, damn if you don't.
That was also submitted. That was also submitted.
We do Titans for 400.
Titans for 400. This surgeon and his laboratory technician, Vivian Thomas, developed the operation that treated blue baby syndrome. If y'all don't get this right. Come on.
Anybody? Threes.
Who is Dr. Blaylock?
That's correct. All right. Dr. Whitehead. For 400. 400, sorry. 3rd years before. Had to put one in there. All right, 3rd years.
Famous last word, 100.
Famous last words. 25 words or less.
Yes.
Who is Dr. House?
That's correct. Encouraging brevity is it's a skill they need to learn. Absolutely. 3rd years.
Famous last word, 300.
300. So technically, this was submitted by like 3 residents. Jenny knows it. No one?
Anyone?
All right. It was Dr. Sugar. I couldn't get it's like correct. My fault. I'm a bad performer.
Yeah.
3rd years.
Titans at the table, 100.
Titans for 100. This surgeon pioneered antiseptic surgery after applying the work of Louis Pasteur. You can see his name in every Walmart and Target.
Dr. Band-Aid.
Yes.
Miles, did you get it?
No one? It was Joseph Listen. No. Put you on the spot and you'll forget everything. 3rd years?
Titans, 200.
Titans for 200. This vascular surgeon from Louisiana helped develop MASH units during World War II.
Ones.
Who is Dr. Bakey?
That's correct.
Wow, Miles.
Didn't even need the full question.
Yeah, okay.
Strong work. It's from Lake Charles, actually, down there.
Titans 500.
Titans for 500. This surgeon performed the world's first successful human liver transplant and is often called the father of transplantation. We need some representation. We were like, this name was seared to our brains at Entrepreneurs New Orleans. Had to know about him.
Nobody?
No one? Who is Thomas Stark?
Yeah.
So Dr. Powell, personal.
All right, interns. We've got 2 left.
Famous for 400.
400. All right. Hey, kiddo.
That is threes.
Who is Dr. Allen?
It's an affectionate phrase. All right. Famous for 500. What did you do to palliate the patient?
Interns.
Who is Dr. White?
That's correct. Had to get everybody. let's tally those up and then we'll do the final Jeopardy. See how much y'all want to risk. So the way we'll do this is I'll have y'all either announce your bet. You have to answer this question. So you can bet up to $1 or 1 point, all the way up to your total to go all in. Look at that. Nobody got this bad right. Yeah.
Oh, interns are 5, 2 or 8, 3 or 2, and 4 to 1,400.
Yeah, 4, 9, 6, 11, 13.
I think we should send it.
This is how I feel.
Trained on calculators. All right, so the fourth years in the lead with 1,300. The second years are in second place with 800. The interns have 500, and the threes are bringing up the rear 200. You can bet between 1 and your total amount. When you all are ready, please announce your bet to us, and then I will reveal the question.
200.
3s are 200.
Threes are betting
All of it.
Okay.
They're trying to get into third place.
All in.
All in for the interns? Okay. So all in for 1s and 3s.
What is that?
Second years?
That's the 4s.
Everyone should go on. It's only fair.
Okay. We got a calculator out.
Yeah, that's right.
1s and 3s win.
1s and 3s are going all in. Fourth years?
101.
Okay. 101. That's strategic. Okay.
Double 800.
Yeah, that'd be 1601. All right. Second years, y'all going all in?
We have to.
Let's do it. All in.
All in. All right. Everyone's all in except for the 4s who were at 101. All right. The final Jeopardy. Total number of combined cases logged by graduating chief residents. You must be within 250 cases to get it correct. This year's class. These 5 right here in the front. How many cases have they logged in 5 years within 250 to get it correct?
This is when I pulled
Within
the
200.
day for him.
Gotta have a buffer because there's no way they can get it
So
right.
Monday.
All the 1s, 2s, and 3s are all in. And they've bet 101.
Yeah.
When y'all are ready with an answer, you can text it to Jenny or come up here and tell us.
Here, I'll come to you. I'll come to you, Bobby. You can, or you can write it down right here.
Right.
Just here. Got it? Okay. All right. Who's next?
It was very clear that y'all stopped logging with the box to agree on a few of them. Yeah. So the pair was like 40, 40, 40, 40.
Except for
And the pair
interns.
said like 75. I did the same. I had exactly 10 on Abramson. All right. You want to announce the answers for us, Jim?
PGY 1's at 6,100. 2's at 9,326.
Wow.
PGY 3's 6,200. And PGY 4's 7,200.
Man, maybe I should have been above or bigger.
PGL ones was 6,100.
It was closest to that.
Yeah. Well, everyone is farther than 250 away. The correct answer is 5,366. Oh, the real number is probably
Fashion,
longer.
they're overestimating.
Yeah, these are the ones bald.
We don't want to tell surgeons.
Where the
20% more than.
All right, so the 43s are the winners. And I guess we'll tie break these three that are all at 0 now. So,
We can be second because we're really close to this.
all right. So the interns are in second place, the threes in third place, and the twos are at the back.
Congratulations, guys. I'm sorry there's no money for awards like that last year. Federal government got involved and wanted to take taxes out. I had to do some manipulating. So bragging rights only, congratulations. We're going to take a 15-minute break. So I'd ask you to be back here around about 20 after, and we'll start the final two presentations.
Sorry, I sabotaged y'all.
Brett, thank you so much. That was fun. Brett.
Huh? What's this? Oh, you have them?
Yeah, you didn't major.
Yeah, I did your category minimums. So y'all have the answer.
When you won. Literally won. Still fact.
It's okay, guys.
Wait, it's not focus?
So which cases?
Like something that doesn't count for credit. You're talking about something that doesn't count for credit.
So what shows up? Are these like the central lines and stuff?
Central lines,
Yeah.
skin, it doesn't count for credit. Like people say, like does not count for credit.
Yeah.
Blah blah blah. All I hear is that they lost.
In those cases, yeah.
I do.
Oh, would have been closer,
Yeah. Yeah. Well, like the real number is certainly higher. That's why. Well, that's my fault because Jenny asked which report I wanted to say the category. I didn't say oldest. He said longest affiliated. Did he drink?
But if you did, because technically it's still drug cases.
What year did it start?
Hey, is Will here today? No, he's out. Did you do something? Brian is on. Ron? Okay, so Will's not here today?
He probably has other, usually
I
has
didn't
like
include grads.
Okay. So my dad is doing the talk at 10:45. We met with Will several times, and there's a very specific way that he had things set up,
Okay.
Because I was like, some of these.
and Will knows it. So I don't know if there's a way to,
Like Dr. White.
like,
Dr. White's like, there's been.
when my dad's talk comes up at 10:45, is there, like, can we even go look at it?
Yeah, what do you need?
Okay. He
There's
had
three
it
left,
set
because
up
then the other five
a
inside the conference.
specific way for a certain size so that he didn't have to scroll. And the words were the exact size. Good morning, how are you?
On that, where those bookcases were.
Okay.
Can we just take a look at it?
They
No,
just
I'm
have,
Jenny.
they just have
Okay.
McDonald's.
You are Shelley.
The other ones that were all,
Nice to meet you.
and most of those are for like 6 or 7 years. Good.
But I was
making another like,
final, so I
it should
had
be a
that
better
one
knowledge
for
test.
uploads this morning.
I had the one.
So both of them are on the screen. I do.
Yeah. And I tried not to like steal the thunder of this experience. I was like, how can I like do this very limited but not like. I feel like I should have done 6 of those and yeah. I'm surprised no. I had more. I could have used several sermons on Yes. I tried to do closest, but I done over like a Price is Right there. The picture started at 77.
Are you going to? Yeah.
That's like and the history is really it's like it's roughly 2 years. We don't really know.
Cindy and I went to estate sales. I got books, a great version of the Shreveport Medical Society done in 1949, which goes over the great beginnings of surgeons in Shreveport, Louisiana, and their vestiges on how they were communicated and how they taught at LSU. Most of them, and a lot of them, were chairs at LSU, and just formed the basis of what became as an epicenter of superb surgical care in Shreveport, Louisiana. We also looked at, Katie, what else? Just anything I could grab and pick up that may have an affiliation with surgeons, with Shreveport, and the history of Shreveport. So this is embedded with not only just the department's vision and my vision on where we actually started. We didn't start with just when we were with LSU. We started decades before that in small hospitals, in hospitals where we were always underserved. So it's an honor for me to present this information, which has been a culmination of just fact-finding, fun-finding, very fun stuff on the history of surgery and the development of the hospital system in Shreveport. As we all know, Shreveport has a storied past, and it all started with the Red River. The Red River is a cascade of waterways that brought people to Shreveport, and that's how Shreveport became very common place for fun, for crime. And if you look at the criminal records of in the annals of the newspapers, the crime, knife and gun club has not changed for over 100 years. If you look at the percentage of trauma patients in Shreveport Charity Hospital compared to now and then, trauma makes up about 10%, maybe 15% of our hospital census. It made up about 20 to 25% of the hospital census back at the turn of the century in the 1900s. So while we think things have changed, it really stayed the same. As you well know, the Great Raft had to be cleared, not only by Mr. Shreve, Captain Shreve, I should say, in addition to the invention of TNT. And dynamite also helped with the steamboat rigging of Shreveport, which really opened up the medical entities in Shreveport with people being able to travel, with the flux of people that ran through Shreveport, and to see some of the census in the hospitals. So the early physicians started with Dr. Clark in 1840. The North Louisiana, which became Shreveport Medical Society, started before hospitals. Actually started before any kind of conglomerated portions of physicians' care. So they were organized before they were even organized, if you think about it. Many of the early physicians were farmers. They didn't come to Louisiana to be doctors. They were Civil War veterans and militiamen. They were actually some of the medics on the field in Pleasant Hill and in Mansfield when the Union forces didn't quite make it to Shreveport. But Shreveport was ready, especially from a medical viewpoint. It relocated to Louisiana for, once again, the fertile ground, the crops. Corn was king, cotton was king, corn was king. We had it all in Louisiana as far as agriculture. They started treating their neighbors. They formed coalitions. They formed doctors groups, and obviously the Shreveport Medical Society was important with that. Now, a lot of people know this, but if you peruse through some of the death rates in the late 1800s after the Civil War, yellow fever took its toll on Shreveport, and with 1,200 deaths, a fourth of the population was gone dramatically. Surgeons actually took part in not only the very dangerous work of yellow fever treatment, but also some of the things that had to happen with postmortems after that horrible story. So when was Charity Hospital first appropriated? When was the name Charity, Shreveport, LSU was 70, 80, 100 years away. When was it made in the literature that we can find? There was no bond sold, there was no governor's signature, and as typical in North Louisiana, we wait and wait and wait on discussions and determinations and decisions from Baton Rouge. It hasn't changed since. That's another thing that hasn't changed. But the first hospital was probably built in Ford and Pierre Streets, known as the Pasture on Moss Side. I've only seen one picture of this. It was a really beautiful area. There was a spring there. It's not where you would see today. Geographically, if you look where Moss Side is now, you would not travel in that area. But it was a site of previous schools. Also, concurrently, probably at the same time that these small private hospitals started, the Marines started a hospital to treat the steamboat journeymen who were getting injured trying to clear out some of the Great Raft. And in 1869 to 1972, 29,000 patients were treated at this hospital in various locations for about $30,000. 1872 Shreveport, Charity Hospital in Shreveport was first mentioned, and we trained the first nurse in 1899. This is an excerpt from the Shreveport Journal back in 1872. A lot of words we don't use nowadays. You'll notice Stoner Avenue. Jacobs was a big Jacobs family that started the First National Bank of Shreveport. So some of the great leaders in Shreveport noticed that. So we continued to ask for state funding for years, 14 years to be exact, before they said, wow, Shreveport are in dire straits. People are dying up there left and right from sepsis. In 1888, we had a bed capacity of 68 for thousands of patient contacts, mostly with infectious diseases. Very few surgeries were done then because of the lack of anesthesia, lack of antibiotics, and lack of technology. It was a pest house for contagious diseases. If you had tuberculosis, you had sepsis from staph or any other infectious agents, you were put in a pest house. And it was basically a place to go and die. It was controversial, just like there are now, about Texas residents coming over here being treated at the Charity Hospital. We didn't want that. This was state money, the little we had. We did not want any outside patients coming from Texas, Mississippi, or Arkansas. In the private sector, T.E. Shumpert, who started Shumpert Hospital in the late 1800s, was upset when paying patients actually came to Charity Hospital and made a big poop about this. So there was some controversy very early on from T.E. Shumpert, and we know his successes in Shreveport. But those things hadn't changed in 150 years. 1904, a new hospital was built at the corner of Texas and Murphy, where the old police station is. This is it. I have 3 pictures. Most of them are from postcards, not any actual pictures, but it had about 300 or 400 beds, not as big as it looks on this. There was fountains in the front. You can see the horse and buggies in the front of the pictures, and also a trolley. Pretty much the same picture, but you can tell the architecture, obviously, circa early 1900s. This is probably the best picture of them all. The livestock were in the front, livestock were in the back. There was all kind of things going on in Charity Hospital at that time. This is some of the patients that were discharged. This is in 1902 after the hospital started. The mortality that I figured from here was from 4 to 12%. And at that time period, it was very acceptable and actually worthy of note that the mortality here was dramatically better than Charity Hospital in New Orleans, which had been in existence probably 70 years prior to this. This is the first really hospital staff. This is Dr. Hunt, who is the chief of surgery, where the star is noted. He has 2 surgical interns there. He has a bevy of nurses, and that's kind of on the first early faculty and patients experience here in Shreveport. Shreveport was very proud of this Charity Hospital. They did everything they could do to keep it solvent for money reasons. Baton Rouge was not giving up money easily, so they had all types of charity events. The hospital was involved with the fire, had to be halfway rebuilt at that time, as you well know. Heating was with gas lamps, and light was with gas lamps, and a lot of fireplaces, and unworthy things that should not be in a hospital. This is the rebuild after the fire. This is in roughly about 1920, 1930. Look at the proud hospital employees sitting out there all dressed in their white garb. And very similar to other hospitals in the 30s and 40s, it was segregated. And you can see whether it was Grady Hospital in Atlanta, Cook Hospital in Chicago, or LA County in LA, almost the exact same architecture. Where on the left, there were African Americans and women in a different ward, and Caucasians on the right side in the right wing. So this did not change, until later in the late 1960s. So they invited people into this nice charity hospital they had. They let kids, even under 12 years of age, even though most of the patients were here with sepsis. They had an opera house that made money at Charity Hospital. They were so proud of this and wanted it to stay in existence. Early operating rooms. I love these beautiful windows. I wish we had them now. It feels so sterile now. We don't get a chance to, like the VA and some of the other centers. I remember in Salt Lake City, I had a beautiful picture of the Wasatch Mountains when we were operating. Probably good now. You don't need to be looking outside. You need to be focused on your operative therapy. One thing for this picture also was, if you look at the masks, the anesthetist had no mask on. The circulating nurse did not have a mask on. And all the masks on the surgeons were under their nose. So not the best practice of sepsis. Same operating room, it's a little different view. This is probably a bullpen that was actually going on at that time. 1915, 1916, you had to run the ambulance service. If you were a surgical resident, these were the surgical residents at that time. And if I'm not mistaken, the third person from the left, I think is a woman, or there is a pompadour with this guy's head. I'm not sure. I can tell, I'm not sure. But the ambulance service had to be run by the surgeons because of trauma. And there was a significant amount of trauma in this area where Shreveport was. You can see the houses in the back. So where were the other hospitals at the same time? We know we had Charity, we know we were building, it was 1930, it was a very rapid growth phase for Louisiana. Natural gas, oil was hitting Shreveport, and there was a lot of money flowing in. Well, T.E. Shumpert, who was actually the chair of LSU, Charity Surgery Program and the Department of Surgery, had a falling out with LSU and left and built his own hospital at the same site where the old Shepherd Hospital in St. Mary's is today. It was run by the Sisters of Charity. The North Louisiana Sanitarium, I think, is the old doctor's hospital. Dr. Lewis Abramson and his son, Paul D. Abramson, which this lectureship is named after, started that. Highland Sanitarium, where Dr. Griffin started, not quite in 1917, but nonetheless, it's a beautiful, beautiful facility to this day, if you go visit. And in Tri-State, obviously, is Wilson, at the exact same location it was in 1926. Tryon Hospital has come and gone. While we're in the exact same location, the original site, the original building has been reconfigured. And actually, Oster is looking at buying this site as we speak. The Pines Tuberculosis, almost every region, geographic region, had a tuberculosis hospital. This was privately run early on with charitable women of the church and taken over by Charity Hospital in 1948. And P&S on Line Avenue, which is now the Spine Center, in 1947. Well, none of us would be here probably without the great goings-on of Huey Long. At least that's what he would think. That he ran Louisiana in the 1930s with an iron fist, whether it was education, whether it was the medical profession. He had his hand and his fist in everything. Funny how things come around, full circle. Populist at home from Winfield, Louisiana, and was assassinated in 1935, just prior to a presidential run against Franklin Delano Roosevelt. So he did build something, obviously, that had never been done before in South Louisiana. It was a medical school. This is the Item Tribune in New Orleans in 1931, 4 years prior to Huey Long's death. The gentleman on the right, Dr. James Monroe Smith, and his surgeon of choice, Dr. Arthur Ladrine from Ville Platte, Louisiana, were all cronies of his. Not the best surgeons in the world, not the best educators in the world. And Dr. James Monroe Smith actually went to Angola at the end and after the assassination of Huey Long, because there was a series of serious malfeasance issues in Louisiana politics, and as you well know, some of that is continued. This is the resident staff in Shreveport Charity Hospital in 1928. Half of these were surgeons. I will point you out to the gentleman right here. It's Dr. E.L. Sanderson, who was a big name in Shreveport. He was from Jackson Parish, just south of Monroe. And he ran this hospital with an iron fist. He did a little bit of everything. He was Huey Long's favorite boy. And when Huey Long suffered a gunshot wound to the flank, he went down and carefully opened the abdomen and he carefully aspirated the retroperitoneum. He didn't open the abdomen and decided not to operate on Huey Long. And while there's many theories, it was thought that Governor Long probably died from a retroperitoneal hematoma from an assassin's bullet. He continued to aspirate, blood pressure continued to drop. He had several units of blood, and Huey Long succumbed of his wound in 1935. This is our resident corps in 1933. And once again, we were part of a 10-hospital system that started by Huey Long in 1931, which basically managed all the charity hospital systems. In 2013, the governor decided to privatize these hospitals, and only one of these exists to this day. 3 medical schools, if you'll notice, most of the early physicians did not have an LSU name. They were from Tennessee, University of Texas, but mostly from Tulane. And a lot of the people who started surgery in the early days in Shreveport were Tulane graduates. After 1931, 35 I should say, LSU New Orleans started, and Shreveport actually started in 1969, not in 1965. This is an early building of the hospital. It's still standing. Used to be Confederate Memorial, now is LSU Health. Early pictures without the medical school, without the Biomedical Research Foundation, and without the nursing school. So this is truly an early picture. You can see by the cars. This is probably in the early 50s, right after they built it. Dr. Hay was chairman early on at Confederate Memorial Hospital. We're moving forward from the hospital that was built in Texas Street and Murphy, and has actually moved to a new medical center that was built in 1953. And prior to Dr. McDonald's arrival here, Dr. Kurtzwick's arrival here, the academic medical center was made up of private physicians. They have trained more surgeons than any of the academic guys ever have. If you look at the numbers, which I'll kind of identify at the end, it just scores and scores and scores of private physicians, extremely talented private physicians, ran LSU Hospital, ran the residency programs, got us into the American College of Surgeons, got us certified in the early 1950s, and this is well before our affiliation with LSU. A great history of local surgeons taking care of indigent patients and contributing to care at a very, very high level. Now they're operating a little bit more modernized now. See the lights? They were scrubbing their hands, mask her up. This is a list, and I have a hard time finding the date on this clipping, but I think the clipping was roughly in the probably late 40s before we moved to the current site, because the hospital at the site that we just previously discussed, the big white building, had 800 beds, almost 900 beds, with a 98% admission rate. So they stayed full 98% of the time, the occupancy. Extremely busy hospital, and you see where this ranked nationally. 3,300 beds in Cook County. You don't see those hospitals. Bellevue, Charity Hospital in New Orleans, and Shreveport's down there at 888, just behind the University of Iowa. Very dramatic number of patients that we took in Shreveport. Visiting staff, no masks. Surgeons, barely masked, and they're looking on. So infectious control would go crazy. Hospital would be firing people left and right if that happened today. Surprisingly, the infection rate was about 5 or 6%, not much different than what we have today. This is an interesting piece of paper that I was asking Dr. Gladney about a few minutes ago. It shows that Shreveport Charity Hospital, I predict this is when Dr. Hurd was the chair in the early 1950s, maybe the late 1940s. It showed where we represented. So this was before 1953 on Texas Avenue, showed the number of cases. And that shows, if you look at the number of patients that were in the hospital and the number of surgeries here, it shows that there was not a lot of patients going to the operating room at that time. Compared, if you had an 800-bed hospital, and these were the cases, in traditional fashion, or in today's terms, we would be doing 5,000, 6,000 cases. But you see, we were limited by anesthesia, by antibiotics, and by technique. If you, Dr. Hurd and Dr. Abramson's names at the top of the surgical staff, Dr. Charlie Black, who I met prior to him passing, was really one of the biggest leaders that we could have had here. He helped form the medical school. His son was actually a surgeon at the VA Medical Center and also finished here. Dr. Gladney's dad was listed on here for a bout of tuberculosis that he shared with me this morning. So a lot of surgeons trained here at every avenue. So what happened after 1953, when this hospital was built? It changed hands. We all know that. LSU was taking care of indigent patients. All of a sudden, the economics became very important. Why was it not going to? Was it going to be solved? Or were we going to be transferred to Baton Rouge? There were so many unknowns. But as you can see, the names of the hospitals changed from LSU Hospital, LSU Medical Center, Health Science Center. We added E.A. Conway, Dr. McDonald did, and also a hospital in Alexandria, which has since gone by the wayside. And now, obviously, we're Ochsner, LSU Health, and St. Mary's Medical Center. And they diverted the responsibility all throughout the state. Nobody wanted to take care of the charity hospital system. The Department of Health and Human Resources in the 1970s changed it to Louisiana State Healthcare Authority under Edmund Edwards. And in 1997, LSU took over. And subsequent to that, they've been privatized since then. A lot of political turbulence, cronyism, and favoritism, which is kind of the way of the world in Louisiana. I get teased at national meetings or regional meetings about, Keith, how do you survive there? I said, it's kind of fun. You know, every day you go to work, there's something that you don't normally see at other institutions. But I will tell you, it also takes a toll on recruiting and things like that when we're looking for new doctors. Dr. Griffin and I talked about this picture last night. He was a resident at LSU. This is the administration building. It used to be the nursing school, right? Dean? It was a nursing school at the very top level. They're playing badminton. The dean said that the resident corps and rooms were 2 or 3 flights above that, and they would always look at the nurses sunbathing out there. Now, don't call HR. Dean is well past that. Dean, sure. What a great place. So we're going to quickly go through the chiefs. I'm not going to go into great detail, but there's certain chiefs at LSU that made a huge showing. They did some of the first cases in Louisiana. We think that New Orleans was the epicenter of vascular surgery, not necessarily the case. So we're going to start way back, and I'm going to rapidly shoot through these so Dean can have his say here. So Dr. Clay, not the Dr. Clay that Kevin and I are used to, but Dr. T.E. Shumpert, born in Shreveport, returned to Charity Hospital. He ligated a subclavian artery here at LSU. A lot of firsts. Stan Shelby did endocarditis operations. There's a lot of people who did first. They wanted to bring the indigent patients to do those innovative operations initially at here at Charity. R.H. Gray, and poor Dr. Shumpert, I didn't mention, he left because of some money issue. And it had to do with the faculty plan that he was taking funded patients here into a private clinic, kind of a rift there, and he said, look, I'm going to go build my own hospital. One of the most successful hospitals Shumpert was for decades in the southeastern United States. He died of typhoid, unfortunately, in 47, and left all of his earnings to the Sisters of Charity. Dr. Hunt, facial paralysis. Larson had 2 2 rolls of surgery, once here and a little bit later, treated an axillary artery aneurysm. Dr. Hendricks, Dr. Garrett, Dr. Gray, Dr. J.C. Willis, who was the chief here at Charity and at Confederate Memorial, who actually helped start Willis Knighton. Dr. Sanderson, the Politico that I talked to you about earlier, true robust chief of surgery who made no qualms about firing interns, firing residents, and firing his fellow staff. He started kind of these issues with Willis Knighton, and that's funny. 1940, Willis Knighton versus LSU. Go fast forward, things hadn't changed. We're all fighting for the patients. The political ramifications of having training programs in the same city. But I'll tell you what brings us together, Ghazi will attest to this, is education, the residents, and our love for surgery. While Ghazi and I are on 2 ends of the spectrum at 2 different hospitals, we agree on several of those things. So the surgeons and the physicians keep things together, and the politicos and some of the hospital administrators have issues that we'll let them deal with. I won't go into that, but he had fights here, he had a fight at Shumpert. He went over there to do a case. They didn't like him over there. I know the feeling, because when I started at Willis Knighton, Dr. Stan Shelby told me, he says, Keith, you need to get back to LSU, do the cases over there. We don't need you over here. We became best friends. Sure. And Fred will probably remember that. But he and Larry were not excited about me and Neil Nanda going to Willis Knighton, start a private practice. They just made us all the more determined. I've made some great friends working with my compatriots over there. This is Dr. Sanderson here. Kind of like this guy. Obviously, I don't know him, but I love his bravado. He fired one of the surgeons you see on the right-hand side. The guy had his young faculty had a cardiac wound. He didn't call Dr. Sanderson in to do it. He said, the guy lived and he did fine. He goes, you didn't call me, you're out of here. And fired him right there on the spot. So that's the kind of guy he was. Couldn't do it nowadays, obviously. You had to go through HR, write about 15 letters. But that's the way it was. Dr. Hurd, one of the first pictures that we had, Dr. McDonald redid some of these pictures of the early chairmen, especially in the 40s and 50s. Dr. Abramson, for which this lectureship is named after. Stand-up guy, goodness gracious. His dad came to Shreveport. He was a Marine, went to World War II veteran. And when he passed away at 59 of a myocardial infarction, just like his dad did, the lectureship and so many awards, including one of the awards Dean got as a third-year resident, was named after a really great surgeon and a really great person in Shreveport, Dr. Paul D. Abramson. That's a picture of Paul right there. First Abramson lecture, 1977. We talked about this earlier. Dean Moore came to Shreveport. Dr. McDonald kind of reinvigorated the Abramson lecture and the Abramson lecture series, and this has continued to this day. I have a list, I didn't put them on here, but I have a list of everyone who's lectured at the Abramson lectures. Once again, a group of people like DeBakey, Cooley, Dean Warren, David Savston, some of the great names of surgery in the United States. Dr. Charlie Black, we mentioned earlier, from Westlake. Grady started and helped really the LSU Medical Center. Dr. Charles Knight, I will tell you, a friend of mine, a friend of Dean's, and he kind of took me under his wing, I'll be honest with you. When I first got here, I was nervous. I said, what did I come back to? It was a huge endeavor coming back in here as a third year. And he and I became friends. He'd tell me, he said, look, you don't need to do this case. Don't operate on this. Or do operate on this. It's going to make you feel better. You're going to get some technical expertise. So he was still kind of running the program behind the scene because we respected Dr. Knight. And it was just a relationship that I've cherished, he and Doc, for a long time. And he really bridged. If you look at some of the writings that Dr. Knight did, you know, when John McDonald took over, the gowns versus the great suits that came in, there was, you know, private facilities that ran LSU for decades. And when McDonald took over, there had every right to be battles and wars and turf battles. But I will tell you, Charlie Knight really nullified those, neutralized those. I have some of the writings, and out to Chuck and his sons, some of the things that he wrote by hand on how he was going to make this happen seamlessly and without you know, degradation of the patient process, the patient care, and also surgical education. That's Dr. Knight in earlier days. Dr. Kerswig, a short period here from '68. He was a Plaquemine native. A lot of people came home to roost and also be at LSU. He was at Notre Dame and Harvard, University of Minnesota, as was Dr. Knight, at a very innovative time at the University of Minnesota. Crazy time, and he came back to Shreveport. He was the chair for several years prior to Dr. McDonald. And John C. McDonald, what can you say about the impact that he's had here at LSU? Not only about the things that he started, but the innovative nature and the surgeons he trained. He trained well over 200 surgeons, directly and indirectly, and had a huge emphasis on the acceleration of what LSU Shreveport represented. He was born in Mississippi, 1-year internship, as Charlie Knight did, here at Confederate Memorial Medical Center, it was named then. He went on to be professor of surgery and chief of transplantation in New York at St. Professor at Tulane. He and Dr. Gerpanis, one of the rising stars who ended up dying in a plane accident shortly after he started at Tulane, did the first liver transplant in Louisiana. And Dr. McDonald was here for 23 years, and also 9-year stint as chancellor, and the first chancellor and the first dean here at Shreveport. Dr. Turnage, Dr. Benjamin Lee, Dr. Griffin, and I listed his name in there because of the importance that he has projected to all of us in this room. And in my tenure in 2019 to present. So lastly, this is the last slide I have before I'm going to start a little introduction for Dr. Griffin. How many residents do we train? How many have we done? Now, once again, inclusive of Shreveport Charity back in the early 1900s, as it comes all the way fast forward to where we are today. So from 1876 to 2020, how many residents have we trained? And I actually updated that to 2026. About 530 residents have come out of the training program. Not necessarily LSU affiliated, Shreveport Charity affiliated, Confederate Memorial Hospital affiliated. But that's a lot of great surgeons who finished here. 200 prior to 1950 and around 330 since 1950. It was accredited in 1951 by the American College of Surgeons, who actually started accrediting hospitals in, I think it was 1914. We've had, since 1876 to 1968, 29 chiefs of surgery, Charity and also Confederate, Memorial Hospital, 6 permanent chairs, and 2 acting chairs. So I think that's all I have for the history of Louisiana. I'd be happy to take any questions before I start. Great history here, and I'm proud of this, obviously. And, you know, I will tell you, a couple of residents came up to me when I first started this lectureship about 3 years ago. They go, wow, Had no idea we had a history like this. We really do. Shreveport has an underserved community. We fought for money, we fought for facilities, we fought for a lot of things over the course of the last decades, but I think we're in a good place right now, especially with our training program. I'm so proud. This man here, I've known for 40 years, and he was one of those guys who stepped into the surgical room where I was about to make rounds with Dr. McDonald. He eyeballed me with his glasses, and I know he was sizing me up. He goes, okay, now what happened? He came back as a third year. Did he fail at the surgery? Is this guy worthy? What are we going to do with him? My junior also was in there, all just academic and extremely facile, asking great questions about patient care. And these rounds were a lot different from the rounds you have. These were in person. We went to the bedside. You made rounds before grand rounds. And so you had to have them patients present. Ghazi will tell you. They had to be sitting up in a chair. They had to have x-rays on the film. They had to have, you had to speak to the patient and kind of teach him and prompt him. Say, look, we got to bring a bunch of guys here. They look very important. I want you to say this, and I want you to say that. Well, obviously the patients didn't listen to me, and I can tell you, I've never been so stressed in all my life. But once again, Dean, Chuck Jr., Chuck Sr., Leonard Goldman, Dr. Eddie all made it better for all of us. Well, Dean Griffin, born in 1940, grew up in Baker, Louisiana, went to Louisiana Tech. Never really figured that out, but I took it and glad he went there. My son is finishing there. Went to LSU Medical School from 1961 to 1965 because our medical school didn't start until 1969. He came to Shreveport then as a rotating intern for 1 year from 65 to 66 and finished his general surgery resident here in 1970. He and Carolyn started their family, I think he said his 4th or 5th year at Shelley. This is Shelley. This is when Dean came back from the military and they were already moving forward with their lives. But Dean went in the military, as many people did after his residency. He was a lieutenant commander for the U.S. Navy, was positioned on USS FDR, Franklin Delano Roosevelt, and the second year was at Millington, Tennessee, and then he came back to Shreveport. He came back to the Highland Clinic. He wanted to practice general surgery. He was ready. He wanted to do thoracic. He wanted to do vascular. He wanted to do a little bit of everything, and he could do it. But he also was a great leader and a friend to many people. So when he came back, he became affiliated with LSU almost immediately. Training, teaching, mentoring, and basically just kind of eyeballing the faculty at that time at LSU. His impact on the American College of Surgeons is more and deeper than anybody almost in the state of Louisiana, except for New Orleans. I will tell you, in Shreveport, Dean has been a fellow for 51 years. 15 of those years, he was on at least 20 committees for medical liability. Patient safety and medical liability, how the doctors could do the right thing for the patient, but also protect themselves from medical legal mishap. And he did it well. He became and really rose to the occasion of a second vice president-elect in 2018. Nobody's ever done that in North Louisiana. Several have in New Orleans and South Louisiana, but Dean is our shining star in North Louisiana for sure. He's a member of the Louisiana chapter. He was vice president of the Louisiana chapter, the president of the Louisiana chapter in '92. He was a member of SAGE very early on, a member of Southern Surgical, which is an extremely difficult organization to get into, and he was the first vice president in 2006. President of Shreveport Medical Society. So not just surgical entities, but medical entities where his cohorts loved him. He was the president of Louisiana State Medical Society in the entire state in 2011. He was AOA in 1965, won 3 awards, which has never been repeated here at LSU and Confederate Memorial at that time. He won the James Campbell Award as the most outstanding intern in 1966, an award that was named after a urologist that had passed when he was 49 years of age, a very prestigious award for an intern. He won the Paul D. Abramson Award, the best third-year resident, and won the Alumni Award for the resident that, in the opinion of all the visiting people, faculty, staff, this is the epitome of patient and physician satisfaction for the medical center in 1970, right before he left. Allen Copping Award is the highest teaching award LSU offers. He won that. Distinguished Service Award. Shreveport Medical Society in 2014, Gold Humanism Award, and he was also in the Louisiana State Medical Society Hall of Fame. Dean, I told you I was going to say a lot of good things, and I'm hoarse now, so I'm going to give it to you, and I want to tell you how much I appreciate you in every way, shape, or form. You've done so much for me in this institution. Get your slides up here.
Son, the podium's too complex when you have to have a IT person come up and set it up. It all works good, except these aren't my slides. Thank you, Ryan. Does the sound carry in the room?
Yes.
Keith, I don't know what I did to deserve that introduction. What are you hiding behind?
I can't tell.
That's phenomenal. Appreciate you so much. He's brought the level of our program up tremendously in his short term here, and great to have him. Thank you, Dr. White. I don't recognize myself in your remarks, but they surely make me look good. Do me a favor, email them to me. I'd use them in my obituary, but no time soon. Patrick Smith was in town. He works in Monroe now. Patrick here? Anyway, Patrick and I have been good friends. We trained Patrick here, and he was in town attending a trauma symposium. And we went out to dinner that night. After a meal and a couple of old fashions, I told him I was going to the Abramson lecture this year. He asked me what my topic would be. I said, well, I'd like my topic to be what I didn't learn in school. He said, that won't do. He said, you need to make your topic surgical errors. Asked him why that would be, and he said, because I consider you the expert in mistakes. You're not friends, but if you got a friend that's friendly, I don't know. I consider it a retroactive compliment. I have one disclosure. Much of the data comes from a closed claims study conducted by the American College of Surgeons several years ago. However, most of the material I'll be presenting reflects personal opinions of my own, as well as some of the things I have experienced and seen over several decades. The study consists of 460 closed claims, nationwide distribution. I began my practice in the 1960s. When something undesirable happened, I called it a misadventure. We didn't use the term errors. We didn't think there were many errors anyway. Errors was too harsh for us. We liked misadventures. A liability crisis, though, came in the early 70s. The Institute of Medicine published 2 books, To Err is Human, #1, and then Cross the Quality Chasm, #2. This ushered in a move toward quality assurance committees to track bad outcomes in real time. In the process, we learned 2 things. We learned that errors were way too common, and we also learned that closed claims and short medical charge were a source of great knowledge. I've organized the American College of Surgeons study into 3 groups: technical performance failures, judgment and decision-making errors, and errors caused by systems failures. Technical performance errors were distributed among several causes. An example of patient-related factors is obesity. These factors make our surgery more difficult and errors more common. A good golfer may find it impossible to place a ball in the fairway when he's required to take a shot from behind a tree in tall grass. Many times we surgeons feel the same way when our patients come to us. Humans are not perfect. The best golfer in the world will miss an occasional 1-foot putt. A bad decision can cause a technical failure. We will discuss system fractures later. In the American College of Surgeons study, there were 144 technical failures scattered amongst 133 claims. 15% of these were caused by surgeons with inadequate skills. Among these cases, almost half occurred when residents operated without an attending. The other 85% involved surgeons that were well qualified, well trained, and well experienced. Amazing that they could have that many errors and be so special, right? We live in a dangerous world. An example of decision-making errors leading to a technical error is illustrated by this major bile duct injury. I'm sure the surgeon that injured this bile duct didn't do it on purpose. His judgment was impaired because of a visual illusion. You think you see a white square, but you do not. That's just part of the background. What you see is 4 pieces of pie missing from 4 pies. Introducing technology can be tricky in our business. One surgeon did a tubal coagulation on his office nurse, bad form there, at her insistence though, even though he had never seen or done one. When the nurse handed him the coagulator, he was disarmed. The scrub nurse was able to help him get through the case. The patient was satisfactory for 2 days, then presented with an acute abdomen. It was found on exploration that the acute abdomen was caused by a coagulator burn to the intestine with leakage and peritonitis. A surgeon-to-surgeon transfer is sometimes advised. For example, sometimes parathyroid surgery poses unique problems, such as abnormal workup, previous thyroid surgery, lack of significant symptoms. For these cases, subspecialty consultation may be advised. Those are the exact unique problems the patient we will discuss now presented with. Instead of referral, which in retrospect wish you had done, the surgeon operated and found nothing but fibrous tissue from the previous thyroidectomy. Regrettably, a recurrent laryngeal nerve was damaged, permanently so, with permanent disability. A large price to pay, given that surgery may not have even been indicated. Work on for causes of hypercalcemia enable one to be more precise in terms of surgical care. It's important that we grow our scopes of practice. The surgical field changes rapidly. I've told residents that I came to work that day and never did anything I learned at school. In changing our scope of practice, we must be very careful to use tools like proctors to grow wisely. For example, I wanted to add mediastinoscopy to my practice. Dr. Frank Kersley was our chairman at the time. I asked him if he would proctor me. He was willing to accept the responsibility. I watched him do 5. He helped me do 2, and the rest is history. Our technical skills decline over time. Dr. Lazar Greenfield, of Greenfield Filter fame, studied surgeons' technical skills over time and learned that on average technical skills deteriorated after age about 55. At age 67, I began gradually giving up some of my bigger cases. By 82, I retired. The only procedures I did that year was repeated peritoneal dialysis, catheter placements for dialysis, and increased cranial pressure. When during surgery a case morphs out of your scope of practice, intraoperative consultations are very helpful. In one instance in the closed claims study, a surgeon operating for a presumed periappendiceal abscess found instead an infected tube and ovary. He consulted a gynecologist who performed a salpingo-oophorectomy, and the patient did well. It's not that the general surgeon can't do a salpingo-oophorectomy, but in the rare instance if a ureter got injured, the gynecologist is covered with credentials appropriate to the case, whereas general surgeons not uniformly for ovary surgery. Another surgeon operating for small bowel obstruction found extremely dense adhesions. He grew progressively frustrated and operated faster and faster, more and more reckless, causing several interotomies and a couple of bowel resections. We must remember that when we face difficulties, it's usually best to slow down. Usually, not always, but usually best to slow down. Set your surgical monitor on slow, and then work your way back into the case. In this case, the patient experienced lifelong short bowel. Let's move to judgment and decision making. Our discussion regarding judgment and decision making will center around three variables: knowledge, professional behavior, and cognition. We may assume that our knowledge is sufficient since we are working within our scope of practice. We practice evidence-based surgery, and we are well trained. We do good work. Behavior is the art of medicine. Other terms are humanism and professionalism. When our behavior fulfills the art, then the art facilitates our knowledge and skill. But absence the art, our knowledge and skill are dormant and wasted. Be ashamed to go to school all these years and waste your education. The behavioral elements of care are those aspects that require diligence, tenacity, vigilance, and time to accomplish relatively ordinary tasks. Dr. Warshaw was a Whipple surgeon in Benton, Massachusetts General Hospital. He performed 2 Whipples a week on average and was the consummate specialist. He could do a Whipple with one hand tied behind him. Residents stood across holding scissors and scalpel waiting their turn, which never came. Dr. Warshaw performed his magic in front of them. Even so, Dr. Warshaw never left a stone unturned when it came to accomplishing an ordinary task with which he begrudgingly protected his knowledge and skill. This is a list of the ordinary tasks identified in the ACS closed claims study. I might read them off if I can. Communicate with patients. Pursue an abnormal symptom or sign. Pursue a postoperative problem. Assess a primary surgical problem. Enlist the support of a consultant. See patients in a timely fashion. Obtain or provide cost coverage. Communicate with consultants. Stay in a proper scope of pressure. Assess the comorbidities before surgery. Follow patients long enough after surgery to get a good result. And check test results. Failure check lab and x-ray results seem to be disproportionately represented. Communication is also disproportionately represented. An example is a case in point. The medical doctor made a diagnosis of cholelithiasis by ultrasound, and because the patient was in severe right upper quadrant pain, the internist walked down the hall, found a surgeon, had the patient admitted, and planned cholecystectomy the next day. The surgery for the gallbladder was removed without event, but after surgery, the patient was unstable in the recovery room. A cardiologist was consulted and found that the patient's x-ray showed heart failure and had never been reviewed by any of the treating physicians. Evaluating patient instability, the cardiologist made a diagnosis of myocardial infarction with liver capsular distension, and the patient had a disastrous postoperative course. From the standpoint of bullets marked in red, the behavioral flaws could be perceived as knowledge and skill issues. Since the surgeons were in their practice, though, these were deemed behavioral instead of knowledge-based. Among the 460 claims in the study, 360 of them had behavioral flaws, some as many as 4 different behavioral flaws. Surgeons are known for using their hands. We must remember we have to use our brains as well. The importance of sound thinking is very important. Thinking is in large part a discipline. We have to diligently think. Regrettably, when we get busy, the first thing we ignore is the thinking part of the quality care equation. We don't get paid to think, we get paid to operate. I don't wonder why we don't spend much time thinking anymore. Some persons have better cognitive skills than others. Jerome Griffin, a medical oncologist in Cambridge, wrote a book, How Doctors Think. Buy it and take it on your next beach trip. Let's look at some cognitive pitfalls to avoid. Know what you don't know. I was covering the emergency room at Confederate Memorial Medical Center. Dr. Carl Goodman was on orthopedic first call. The patient came in with severe fracture of the forearm. I consulted Dr. Goodman. I remember standing with him while we read the x-rays as the nasty dripping from the fluid dripping wet reed, and Dr. Goodman said nothing for what seemed like a long time. I finally asked him what he thought. He simply said, I don't know. I don't know. He could not have said anything that would have impressed me more. He avoided an arrogant clinical certainty response and called his higher call partner. Together they provided great care, and Dr. Goodman learned for the next time around. When you don't know, look it up. It's there in the device in the palm of your hand. We used to go to the library at night to get that information. That's in the palm of your hand. Humility prompts us knowledge, while arrogance presumes that study is unnecessary. The arrogant are secure in their self-righteousness. The arrogant take shortcuts, which are not in the best interest of their patients, while the humble dig deeper. When we attribute our errors to others, we lose a learning opportunity. Errors of attribution are common in quality assured committee deliberations. Always look for the worst case scenario. Confirmatory bias has no place in evaluating post-operative problems. A surgeon should blame illness on medication only after a careful search for more serious causes, like abdominal abscess, fistula, anastomotically, and sepsis. An aggressive surgeon is referred to a patient with obstructive jaundice and a pass in the head of the pancreas. During surgery, he finds the middle colic vessels in phase engulfed by the tumor. The superior mesenteric artery was far out of sight, buried in the mass. It's time for a cognitive timeout, but this patient did not get a cognitive timeout. He got aggression and finally succumbed to the risk of surgery for a case that was not for a cognitive timeout, for the lack of a cognitive timeout. The opportunity to bypass was missed, and the consequences were disastrous. Demon surgeons face the opposite mistake, taking the small tumor and leaving it to chance over time. Cognitive timeouts help us make good decisions between resection and bypass and other decisions. Don't paint yourself into a corner. Always have an escape route. Charlie Knight Sr. taught me that. Chuck, your dad was a master at figuring that out. Systems of care create problems in 85% of cases. Notice that the surgeon is at the top of the list. It reminded me of an airplane pilot getting out and kicking the tires and checking the gas level. That's your job. You've got the responsibility by virtue of your training and your expertise. Don't forget it. Participate on these committees. I talked to Amy last week. Amy runs our program. I said, do you think you get good cooperation? She said, I get wonderful cooperation. All the residents are so good, the faculty says it's just amazing. I did what Keith's doing now. I never got any cooperation at all. I don't know what you do. Heavy-handed. I don't know, whatever. Let's review a liability case that I was involved in several years ago. A middle-aged patient presents in the emergency room with left lower abdominal pain. She is tender with mild rebound. Her temperature is 99.8 and her physical exam is otherwise normal. A CAT scan is performed that shows fat stranding around the sigmoid colon. They make a diagnosis of diverticulitis. She's placed on antibiotics and dietary measures. She does well and goes home in 4 days. She comes to see the surgeon 4 or 5 months later with recurrent abdominal pain, all on the left side. She and the surgeons elect to perform a low anterior resection for diverticular disease. At surgery, the sigmoid colon was thickened, and it was a couple of the small valve were adherent to it, but ultimately the surgeon was successful in resecting the tumor, the diverticular specimen. A double stapled anastomosis was performed, and the rectal pouch was filled with air. Bubbles were present in the fluid, prompting additional exploration. There was one small area on the steeple road that didn't look just right. The surgeon placed 3 stitches, repeated the bubble test. The bubble test was negative, and the patient did well, and on the 4th day of her hospitalization was ready to go home. The next morning, her surgeon came in just before she was leaving on a weekend vacation, and the patient had recurrent abdominal pain. That was alarming to the surgeon, but all else was negative, and the surgeon suggested that they watch her through the day just to see, to be sure that everything was okay. She felt like maybe it was just gas. His call partner would come by to release her that night. Before leaving, the surgeon handed off the case on a good handoff to an on-call surgeon. The call partner was late. He was making rounds for 4 different surgeons. He was busy. The patient was anxious and ready to go home. She didn't feel that good, but she was ready to go because they told her she'd be ready. The nurse called the on-call surgeon, who asked her if the patient was doing well. The nurse said that the patient was okay, but forgot to tell the on-call doctor that the patient had required 2 narcotic injections that afternoon. The patient got discharged without being seen, and with instructions to call her surgeon on Monday. That night she didn't do well at home. The pain tablets were ineffective, and all day the next day she continued to have abdominal pain and was getting worse. She reported back to the hospital for additional evaluation. A CAT scan was performed, revealing free air into the diaphragm, no free fluid, modest peritoneal inflammation. Ignoring the worst case scenario, the on-call doctor said, oh, she's okay. That's just leftover air from the previous operation. He said, put her in the hospital, I'll see you in the morning. He told the nurse to admit the patient and would see her in the morning and was going out for dinner. The patient did poorly through the night in terms of pain. She began running fever, and the next morning her systolic blood pressure dropped out. Her temperature went to 103, and she became confused and unresponsive. They took her to the operating room and did a Hartman's procedure for leaked anastomosis, but the patient never recovered and suffered the ultimate complication. A review of this case involves 3 breaches of standard of care: discharge without being seen, delayed treatment of a complication, and a technical error with an anastomotic bleed. The surgeon, primary surgeon in this case, that performed the first surgery was not held culpable because she did a good job. She was present. She did what was taken, but it was nothing that she could do. The leak, it chalked up to what we would call personal failure. We're not, remember about the golf ball guy. Took a swing at a 1-foot putt and missed it. That's part of our practice. We miss the ball sometimes, but not because we do it on purpose. So we err because we're human. We miss the ball. We work in complex systems. Not exactly rocket science, I guess, but it's about hard enough for me, I'll say that. We try to be perfect, but we fail. Our patients present with problems that are overwhelming. We sometimes fail to enable knowledge and skill by failing to engage the art of medicine. So going forward now, we're about to wrap this up, and I want to repeat that. We sometimes fail to enable knowledge and skill by failing to engage in the art of medicine. Oliver Wendell Holmes is a name that some of you people are familiar with. He was an iconic figure in multiple venues, one of which was he's a medical doctor in Boston. He said one time when he was doing the commencement address at Harvard Medical School, he said a doctor has but to applying the best of his knowledge to engage the art of medicine. That quote references exactly what I learned while I worked 3 months to prepare this preparation for you. You didn't have to spend 3 months. You can take it from me and Oliver Wendell Holmes. We focused on humility when we discussed Dr. Goodman's decision to help to treat an arm fracture. This paraphrased quote from Holmes also focuses on humility. In referencing a doctor in Paris, back in those days, the United States people trained in Europe. We didn't have a mature training system for doctors yet then, that's decades ago. And so he found himself in Europe in the company of a doctor named Dr. Pierre Louis. And he said that Pierre Louis could draw students to him because of his humility in the face of nature. In the face of nature being a sick patient he couldn't control. Patients bring us big problems, I'll tell you. We cause them trouble sometimes too. This doctor is as humble as Dr. Goodman and Dr. Lewis. He is overcome by the disease he can't conquer. What can I say that this picture doesn't say for me? The artist clearly shows the stress this doctor's under. Humility, not a bad trait to have. So what did I learn that was not in school? I learned that errors make us humble. In other words, if we know we're not perfect, we have to be better. We have to do a better job. We have to study more. We have to do our studies, not just that, but we have to do lifelong learning. Lifelong learning. Proverbs puts it this way. We're talking just about eras here, you and I. But Proverbs takes the world in tow and says in Proverbs 11.2, pride leads to disgrace, while humility brings wisdom. So what about the Holy Grail? We've talked about humility. We've talked about lifelong learning. We've talked about wisdom. The Holy Grail is elusive. It's very coveted. It's almost never reached a goal of great value, usually associated with healing and enlightenment. I was walking down the hall, 3G, in your hospital, with Dr. McDonald years ago. We had just completed rounds. He was holding his pipe, left hand, walking with his characteristic shuffle. He was president of the Southern Surgical Association, and his presidential address was pending. I asked him what he planned to speak on. He hesitated, but finally said, I'd like to speak on the Holy Grail. When the time came, he spoke on thyroidectomy instead. I think he gave it up, as all of the sages have. All of the other cultures, all of the other religions have always tried to figure out the Holy Grail. So what is the Holy Grail after all? Well, I'm not planning on solving that problem today. Don't worry. As we pursue our lifelong learning, we become wiser. One little sugar cube at a time. Don't give up. Continue on. The Grail is out there somewhere. Among our successes, we have failures. Our errors have made us humble. Our humility has led us to seek knowledge on a lifelong quest for excellence in surgery. On our quest, we are collecting wisdom, one small increment at a time. Perfection is our goal. Knowing that it's not available does not deter us. We stay the course. Wisdom will accrue, and excellence will be our reward. But for the Holy Grail will remain evasive. We will never get you. I think I saw somebody open the door. Was that the Holy Grail, or was it one of y'all? The Holy Grail may be watching over us. We don't know. But as we stay the course, excellence is our reward. But the Holy Grail remains evasive, totally secure in knowing that perfection is its domain, not yours. Thank you.
I've directly deposited your honorarium. It's huge.
Put it in the resident education
Directly from state. This memento gives you Dr. Dean Griffin, Abramson Visiting Professor, June 18, 2026. And grateful appreciation of LSU Health, Shreveport, Department of Surgery, and thank you. We got one other thing, and we're going to let you go. Not least, put this in the Hall of Fame.
Thank you.
You're so welcome. All right, I guess the next part, Dr. Sid. Start working on the
Well, this is the part where we gather for all today. Realistically, this is the best part of this time. And these residents have worked 5 long years, some longer, but definitely they have sacrificed a lot, and they've definitely led our program from the top. And I'm so happy and honored to be here and excited to honor these 5 residents. And so obviously this is just the first part. We'll still have the second part where we actually get to have a nice dinner and get to hear their thoughts. But once again, this is really why we're here. This is why this program exists. Obviously, we want to send forth all of you to be representatives of what we do, and I know that y'all will all make us proud in the next stage. So once again, just please join me in congratulating our 5. I guess we will go ahead and hand out the plaques and our first is Dr. Bromley. Let's do that and we'll do one.
We'll do one in a second.
All right, our next one is Dr. Gregg. Next is Dr. King.
That's joining us as an assistant professor here in a few months.
Next is Dr. Parrish. All right. Last but not least, Dr. Trosky.
Once again, thanks everyone for coming. This is going to conclude our graduation ceremony and our Abramson Lecture. Dean, keep coming back and seeing us. Appreciate you. Carolyn, thank you for all you do. And I'd like to have the residents go to the bottom of the stairwell if we can take a joint picture, and the faculty also. I'd like to have a joint picture with the residents and the faculty. Have a great day, everybody. Thank you.
Thank you, Lisa.